This is Introduction to the Difficult Airway. This is the first lecture in a two-part series focused on the difficult airway. This really centers around the difficult airway algorithm. And we're going to get into a level of detail and depth that you probably haven't been to with airway management. Additionally, we're going to begin with an anatomy review. We're going to look at some pharyngeal innervation. We're going to look at some components that are necessary to understand for the difficult airway. So now let's get into this presentation. All right, so when it comes to difficult airway, we're going to talk about some challenges because you guys in the intro class and in Basics 1 and Basics 2, you guys have talked airway, you guys have talked induction sequences, but this is completely different, okay? We're going to do an anatomy review. We're going to talk about difficult airway classifications. There's an updated airway algorithm that we're going to spend a good amount of time talking about that you have to know. It's not should I know it, do I need to know it, it's you have to know this. And we're going to do an equipment review, and then in Sim we're going to kind of look at the things that we've talked about today. So when it comes to understanding the anatomy classifications and algorithms, this is to ensure patient safety. This is critical in anesthesia, all right? That difficult airway algorithm, that's so important because if something happens, all right, if you have, say, a poor outcome, okay, you induced somebody, you showed up at a code, and for some reason the airway was not obtained or they had an anoxic brain injury in the process of it, do you know what you're judged on? You're judged on the go ahead. How well you follow the algorithm, okay? Because when it comes to, I mean, like even a code, like ACLS. ACLS is the most basic of things, all right? But if you just decide to not give epi in a code, all right, and someone goes and does a chart review, you're going to get hosed for it, all right? So with the difficult airway algorithm, that's so important, and one thing that we'll talk about and we'll practice, but it's cricothyrotomy. You know, no one's dead until you've cut their neck, all right? You don't stop a code because you don't have an airway. You cut somebody's neck, all right? That you have to do that, all right? You have to be prepared to do that. Do I want you to do that? No, certainly not. I want you to be able to get it in any other way except that. But you have to be prepared to. So when you think about complications from airway management, what are some common complications? Common. Say that again? Swelling. Okay, swelling, yeah. All right, what else? Okay, all right, so laryngospasm. Think more so just with direct laryngoscopy.
Obesity.
Say that again?
Obesity.
Okay, all right, think more so complications as in like something you might cause, like maybe a dental injury, all right? Bruised lip, bleeding gums, okay, anything like that. All right, what's another more severe complication? Maybe pulmonary aspiration, all right, and then we talked about truly severe and anoxic brain injury or unfortunately death. Early recognition and a methodical approach to airway management is essential. That helps to mitigate these risks, that helps to make things safer for patients, but it also makes things better for you, all right? That first case in the morning at 7:30 in the morning when you are energized, your coffee's kicked in, you've been up for an hour and a half, you're wide awake, all right? You've got an amazing plan. But when you're woken up out of a dead sleep at 3 a.m. because you were in the call room and you're exhausted because you worked 18 hours already, and they tell you there's an emergency airway in the ER that you have to run to, or they're coding somebody and they can't get the airway and they're calling you, all right? That's a completely different situation in a scenario, all right? And that's why we have these algorithms. That's why we have this lecture. That's why we have so many of these conversations, because you have to be able to, on little to no sleep, be able to perform at the highest of levels in order to not only obtain somebody's airway, but do it safely. So that's why this lecture is so important. So when it comes to airway management, we talked a little bit about this: airway trauma, unanticipated tracheostomy, anoxic brain injury, cardiopulmonary arrest, and death. Has anybody seen somebody desaturate? You guys have shadowed some? Okay. I like Peyton's, yeah. Okay. All right. So I don't know if you guys have seen this before, but when patients start to desaturate or their sat really, really drops, what happens to their heart rate? Okay, it starts to drop. Okay, why is that? Yeah. All right. And already they're hypoxic, okay? Because if you properly pre-oxygenate somebody, you should have about 4 to 5 minutes of apneic time before your sats hit 90%. Okay. Now, in large people who have no reserve, that's not true. By the time you get done pushing your induction meds, their sats are already starting to drop. Okay. But for the normal healthy patient, you've got a few minutes. And that's why, whenever you're learning, that's why it's so important to pre-oxygenate your patients, properly position them, so you have time to not only take a look, but take a look again if you don't see it. When you start seeing heart rate changes, when you start seeing color changes, I don't care if the pulse ox is reading 85%, you need to be ventilating those patients, all right? Ventilation is what saves lives. It's not intubation. Intubation is a plumbing technique. Anyone can connect one pipe to another. Ventilation is what's going to save somebody's life. And as long as you can mask ventilate somebody, I don't care if you get the airway or not, you can mask them until your drugs wear off and you can wake them up, or you can mask them until someone else can come along and get the airway. So in severe cases, airway trauma can happen from repeated attempts, okay? The definition of insanity is what? And expecting a different outcome, right? Okay. Oh, direct laryngoscopy, horrible view with a MAC 3. Let me switch to a MAC 4. Let me switch to a Miller. Hey, you're really good with a MAC 3. Why don't you come over here and look? All right. When you walk in to assist somebody, or you guys are in that role of going in to either educate students, or maybe you're working with newer CRNAs, all right? By that second look, they should be doing something remarkably different. All right, if they haven't already switched to video laryngoscopy, they probably should. All right, if they have tried video laryngoscopy and either they cannot get, either the angle is too acute, the airway is incredibly anterior, you need to be doing something different, whether it's a rigid stylet, whether or not it is changing position. Okay, the majority of the time, poor positioning is probably like 50% of airway struggles. All right. I'll give you guys a good example. Has everybody done or been in the cysto room? All right. So with the cysto rooms, they have a cysto table. The back of it normally doesn't raise up, okay? Because there's fluoroscopy with that whole table, and it's specifically designed for those cases. So you can't really raise the back of the bed up, and you can't ramp those patients up. All right. I was with a senior student and very, very large patient. So I'm like, okay, let's go ahead and move them over. All right, and let's get them positioned where they should be. What's the number one rule in anesthesia when it comes to that? What should you probably always have? Where should the patient be? Probably at the top of the bed, where it's probably easiest to intubate. But there's two of us. I've got a senior student. He's great. Shouldn't have any issues. All right, we properly position. We go ahead and induce. We pre-oxygenated the proper 3 to 5 minutes, and he struggles with the airway. All right. And I'm like, okay, take another look. And I see our sats go from 100. Now they're 94%. And he's like, and I'm like, hey, let's go ahead and ventilate this guy. He's like, oh, no, I've almost got it. Sats are not 90. I'm like, let's go ahead and ventilate him. And he looks back up. And by the time he put the McGrath down, put in an oral airway, and held a two-hand mask, his sats were already 70% and dropping. And they dropped to about 50%. I'm like, all right. Had he responded probably in the 20 seconds that, he delayed, probably wouldn't have dropped to 50%, probably would have been 70, but it was still a precipitous drop. All right. So now this guy is poorly positioned. I had a lot of confidence in this student. Now I have a lot less. All right, take one more look, and if you don't get it quickly, all right, I'm going to go ahead and look for you. And so he goes ahead and looks, and he's like, I've got this terrible view. He's like, I just see the base of the cords. And I'm like, why don't you pull your McGrath back a little bit? Just give yourself a little bit more working room. All of a sudden he has a grade 1 view and can intubate the guy fairly easy. All right, that situation should never have happened. I shouldn't have been so cavalier. I shouldn't have probably had the patient poorly positioned. But that is literally, especially in anesthesia, when you do this hundreds and hundreds of times, you can become somewhat, I don't want to say desensitized, but, and you should never have the attitude of, I can get any airway. That should never be your thing. All right, because there will be difficult airways that arise unexpectedly. But you should have the attitude of, I'm going to do the safest thing for my patient. So whenever you're in those situations, cognitively think, what is the safest thing for that patient? All right. Now, whenever you are working with smaller people, whenever you're working, on your own, you may, 99% of the time, you may say, hey, go ahead and have the patient position themselves, and I can reach over and intubate, or I can put in an LMA. But if anything was to go wrong, if you were to really, really struggle, if they were to desaturate, you're hosed. All right. No one is going to be like, you know what, they did the right thing by having the patient halfway down the bed. That's something to keep in mind. And unfortunately, we get somewhat desensitized to it. And the staff in the room can be oh so difficult. They can say, well, so-and-so, we don't have to move his patients after they're asleep. Or, oh my gosh, are you trying to kill our backs? You hear that one a lot. Well, do you want to even do the case? Because if I don't get the airway, we're not going to do this case. So let's do a little bit of an anatomy review. So when you think about the upper airway, we have the mouth, the pharynx, hard and soft palate, tongue, uvula, tonsils. So these are crucial structures to know and to recognize. So whenever you perform a direct laryngoscopy and your CRNA says, what do you see? The tongue. All right, that should be a given. You need to be able to identify your structures. That's why I think your first couple weeks in the OR, when you guys are actually intubating, I think using a video laryngoscope is a wonderful tool. Alex, whenever you trained, how many video scopes do they have at Madisonville your first year?
I think we had to go to a different room to find them, so it's probably a handful. Now they're in every room.
Right. That's been a change in the last couple of years. Where I trained, I did my first year in Moorhead, Kentucky at St. Clair, and this is 2015. They had one glide scope. All right, and there was a CRNA who was just a good bit older. The first case of the day, she always had it. No matter what, she would try to get it in her room and kind of keep it in her room in case she couldn't intubate them, because she couldn't really mask well her hands. She had really bad arthritis. So that's completely different now. Most places have a McGrath in every single room. With the McGrath, you have a couple different blades. The X3 blade is going to be a little bit more designed for the difficult airway. Are we missing anybody? No, we're not? Okay. That's right. You guys have 21. Right. Okay. I had that thought of like, hold on. Wait a second. The other class is 22. So the X3 blade is going to be more for the difficult, more anterior airway. The McGrath, the 3 and the 4. The 4 is going to be for that larger man. The 3 is probably for your ladies and your smaller men. So be familiar with your video laryngoscopes. You also have glide scopes. You have air tracks, and we'll talk about those here in a little bit. But become very familiar with this anatomy. Whenever you're performing a MAC or a monitored anesthesia care type case, and you have somebody who is obstructing, all right, say, what's a good MAC case? Say a portacath, all right? You've got a face mask on them, you've given them some propofol, maybe some Versed, some fentanyl, and all of a sudden that patient is obstructing and they stop breathing. Peyton, what's the first thing you're going to do to them?
Reposition the airway, just try to open them up.
Okay, perfect. Reposition the airway. Why do you need to reposition the airway? What has happened?
The axes might be off and closed off the airway.
Okay, excellent. All right. Somebody else. What else could have happened with the medication we give? What does that do to those muscles and structures? Yeah, it relaxes them. Okay. So you have airway collapse. Okay. So repositioning is crucial. All right. Now, when you reposition somebody's head, how can you do it? Ethan, how are you going to reposition somebody's head whenever they're snoring and obstructing? Or maybe you see that rocking motion.
I'm going to tilt their axis more posterior.
Okay.
And you can just place pillows under the back of the scalp.
All right. And so you want that airway nice and open. All right. What if they're still obstructing? What are you going to do next? Okay, oral airway. All right. Upper airway obstruction is normally caused by what? The tongue. Yeah. All right, excellent. If somebody tells you they have sleep apnea, what should that already cue you in on? Okay, yeah, it might be a little bit more difficult of an airway. They're probably at higher risk for obstruction. Okay, so then you're going to want to have your airway adjuncts out. All right. So a thorough understanding of this anatomy is essential for not only managing somebody's airway, ventilating them, but also planning. Okay? You should always have your plan A, and then your plan B, and then your plan C. Okay? So if your plan A is to max somebody and have them nice and deep, and then they start snoring and obstructing and desatting, plan B is probably going to be, I'm going to go ahead and have an airway adjunct. I'm going to go ahead and put an oral airway in. I'm going to go ahead and put a nasal airway in. All right? And if they're still obstructing, if they're still not doing well, what might you do? Nasal airway. If that doesn't work, I'm going to put in an LMA or probably intubate them. So when you think about the pharynx, it's divided into three regions. You have the nasopharynx, the oropharynx, and the hypopharynx. Each section really serves a specific function. Okay? When you think about the nasopharynx, you think warming of the air, you think about your nasal turbinates. And when you think about maybe the hypopharynx, you think about facilitating swallowing. The upper esophageal sphincter is crucial in sealing the trachea during swallowing. When it comes to the pharynx, this is a critical site for airway obstruction, especially in the oropharynx due to what? The tongue. We mentioned that already. You need to know the sensory and the motor innervation of these regions. This is primarily by the glossopharyngeal and the vagus nerve, and these help in predicting and managing airway challenges. So you should be able to, if I took everything off this image and I said label it, you should be able to label this image. Hint, hint, wink, wink. All right? So when you think about the nasopharynx, all right, what are some structures that could maybe create some difficulty performing a nasal intubation? Adam, what do you think?
I was right.
Say that again.
Sorry, I was right.
So when you think about the nasopharynx, what do you think are some structures that could get in the way when you're performing a nasal intubation?
Nasal polyp.
Yeah, okay, nasal polyps. Yeah, and what if you hit a couple nasal polyps, what would happen? Lots of bleeding. Okay, what can we use to maybe mitigate that bleeding risk? Like, yeah, Afrin. Okay, and what's that going to do? Yeah, that's going to vasoconstrict those blood vessels. Okay, so nasal polyps, your nasal turbinates. Okay, all right, and if you have somebody who's had turbinate reduction, or you have somebody who has had a deviated septum and they've had corrective surgery, oftentimes those patients have very, very dry nasal passages, okay, because your turbinates help to warm and humidify that air. So if you have somebody who has no nasal turbinates, they might breathe really, really well out of their nose now because they had some type of obstruction, but they're likely going to bleed and bleed whenever you nasally intubate them. So lots and lots of Afrin, okay? When you think about the oropharynx, we've talked about the tongue, how it is the main component of airway obstruction, all right? So when you think about, say doing an oral intubation, how should you, if you have somebody in front of you and you're going to go ahead and intubate them, and you're using a Mac blade, I think a Mac is a great blade to learn with. I think the Miller requires a little bit more finesse. Alex, what do you use?
Using Mac 3 for.
Yeah, I use a Mac blade for almost everybody. Mac 3, Mac 4, it doesn't matter. What is the correct way to insert your blade into somebody's mouth? Ashley, talk me through it. Yeah, Mac blade.
So you're gonna get turned, and then once you get in your mouth, then straighten it and be able to.
Okay, and what do you want to do with the tongue? What do you want to do? There's a word we... Sweep it, right? Okay, sweep the tongue out of the way. Okay, so if you have your blade in somebody's mouth and your tongue is falling off, okay, towards the right side, I know I'm backwards from you guys, if it was like this, okay, you haven't swept the tongue properly. That's going to obstruct your view, all right? So whenever you really sweep the tongue out of the way, okay, it should be falling off to the left of the blade, and whenever you lift and you're in the vallecula, that's going to literally pull the epiglottis up and the vocal cords down, okay? And you should be able to have a good view. Who's somebody that might be a little bit more difficult with a Mac blade? Javier, can you think of? What do you guys think? All right. Say that again. Yeah. All right. Or somebody with limited mouth opening. Okay, if they have a recessed chin, all right. So those people who have that recessed chin, limited mouth opening, it's going to be hard to get that curved blade in their mouth. A lot of times we go for a straight blade or a video scope. And you're going to, and I think somebody mentioned this, but whenever you have that patient, you're assuming they're going to have an anterior airway. Okay, so that's going to be your plan A. I already know whenever I'm going in, this is going to be a little bit difficult. And when you think about your laryngopharynx and you think about your vocal cords, your trachea, your esophagus, that's where a lot of your sore throat comes from. So what are some things we can do to mitigate post? It's post-operative sore throat. That's actually one of the most common complications for outpatient anesthesia. You hear someone talk about sore throat. It's terrible. Say that again? Okay, hurricane spray. All right, what's in hurricane spray? Okay. All right, so hurricane spray is typically lidocaine and tetracaine, or you can use an LTA kit, so lidocaine in the trachea. Some people will spray the vocal cords. How long does tracheal lidocaine last? Do you guys remember, you guys probably covered this in regional, but tracheal uptake of local anesthetics is actually fairly quick, okay? So at most, tracheal lidocaine is going to last about 45 minutes. So if your case is going to take an hour or more, do you think an LTA kit is going to do much good? Probably not, all right? Although a lot of us get into the routine of doing it, it's probably not as useful. Now, if it's a super, super quick case, all right, say this is a quick fest, so functional endoscopic sinus surgery or an MSDL where they're just going to take a biopsy in the airway, and this is a 15-minute case, and you use an LTA kit, what's something you should keep in mind whenever you're giving a report in PACU? Yeah, they're going to be numb, and what could that lead to?
Obstruction.
Yeah, okay.
Their tongue.
Yeah, or if the nurse says, oh, hey, go ahead and take a drink,
Oh, yeah.
aspiration, okay? So you have to keep that in mind whenever you are anesthetizing somebody's airway, all right? So what's significant about the cricoid cartilage whenever you think about your trachea? Is it complete? Yeah, okay, so 360 degrees. All right, all your subsequent rings are what? Say that again? Yeah. Do you know what amount of degrees? Like 270 is normally what they say, textbook. So keep that in mind. All right, upper respiratory anatomy. So the nose plays a critical role in warming, humidifying, and filtering inspired air. Your nasal passages have a large surface area, and this is aided by the turbinates and the sinuses. It conditions that air before it reaches the lower respiratory tract. But this also creates airway resistance to airflow, okay, especially in somebody with septal deviation, any changes in their sinuses. And somebody who has nasal congestion also is at risk for that nasal obstruction. When you think about the oral cavity, it's separated from the nasal passages by the hard and soft palates. The soft palate is actually a movable structure that's going to help prevent food and liquid from entering the nasal cavity during swallowing. This function reduces the risk of aspiration and is critical in maintaining airway integrity during anesthesia, especially in patients with obstructive sleep apnea or any anatomical abnormalities. So the nose, it's going to condition air by warming and humidifying it and filtering it. All right. The soft palate is going to prevent food or liquid from entering the nasal cavity. And airway resistance, higher in the nasal breathing due to the turbinates and the sinuses. Okay. And we know in nasal intubation, you're more likely to have bleeding. You're more likely to have irritation. That's why we use a vasoconstrictor of sorts. So the primary site of obstruction in the nasopharynx, lymphoid tissues such as the adenoids are primary contributors of airway resistance. In the oropharynx, we know it's the tongue. That's the predominant site of obstruction. Okay, especially in patients with obstructive sleep apnea or excessive tissue mass in the oropharyngeal region. When you think about somebody who has obstructive sleep apnea, if they are adequately being treated for it, what are they normally using at home? Okay, so what does CPAP stand for? Okay, so why does CPAP help sleep apnea? Yeah, keeps them open. Okay, so you have that continuous positive airway pressure. So head positioning is crucial. All right, use of airway adjuncts, like an oral airway, like a nasal airway. These can be critical in addressing these challenges. If you place an oral airway, okay, what should the patient no longer have? Okay, right. if you place it and the patient's a little too light, what are they going to do? Start coughing and retching. Okay, patients don't like it. They can have a laryngospasm if they're too light. So you need somebody sufficiently deep enough. So how can you tell if somebody's deep enough before you put in an oral airway?
You can suction right there.
Okay, yeah, suction, yeah. All right, that's one way. You jaw thrust them. Okay. If they respond to your positioning of the head, you can take a tongue blade, really opening the mouth and the tongue. If they start coughing and gagging on the tongue blade, probably don't want to put the oral airway in. Now, a nasal airway, okay, what's so nice about a nasal airway is once it's in place, you can actually lighten those patients up, okay? Because it should not, unless you have used, too large of a nasal airway, it shouldn't really elicit that gag reflex, okay? A lot of times what you'll see people do is they'll put lidocaine jelly on a nasal airway, all right? So this way, in about 10, 15 minutes, that nasal passage is nice and numb. This way, whenever you lighten that patient up, they're not coughing and gagging, and they don't even know it. If I'm doing like gastric sleeves or cases where I'm dealing with patients with a larger BMI, my typical post-op instructions are for the PACU nurses is take out that nasal airway when the patient can go, hey, something's in my nose. All right, have them nice and awake. Whenever you think about that lymphoid tissue, I mentioned the adenoids, I mentioned in the nasopharynx, the primary contributors to airway resistance. If you do not use a vasoconstrictor or you forget to do it and you have a significant bleed, all right, this can become a very, very big deal. All right, you may end up having an ENT surgeon come and do nasal cautery. Who would be someone that you might want to avoid a nasal intubation with? Okay, right. Okay, anticoagulated patients. So who's on anticoagulants? I like it. Yeah, a lot of people. Okay. So if you see a patient who has a history of AFib, all right, that's a good cue to start thinking, oh, I should look. You should be able to do a good medication review. All right. If you then look at, if you're doing dental cases, all right, and you're with a dentist, they say, oh, well, I prefer a nasal intubation. Yeah, I normally do too. However, this patient is on anticoagulants. Can we do an oral ray? Can I move the tube for you? Something like that. I know a couple times where people have had some pretty severe nosebleeds, and we've had to call ENT in to cauterize. It's not very fun. Okay. So the pharynx, that's going to extend from the base of the skull to the cricoid cartilage. We've talked about the nasopharynx, the oropharynx, the hypopharynx. So the nasopharynx anteriorly is at about C1, okay, and it's bound to the soft palate. So in that, you're going to have your openings for your auditory tubes, the adenoids, sensory innervation from the maxillary division of the trigeminal nerve. With your oropharynx, so this is going to lie between C2 and C3. It's bound by the soft palate superiorly, and I think the epiglottis inferiorly. Its anterior and posterior pillars form the entrance to the oral cavity, and this all plays a role in swallowing and airway patency. So you should know, and I mentioned this earlier, hint, hint, wink, wink. Huh? Yeah, does that work for you? Yeah, perfect. Sounds good. So you should know how to eloquently label a nice airway diagram. Keep in mind that the pharynx serves as the conduit for both the respiratory and the digestive systems. We have distinct anatomical regions that play a role, and you should be able to label these, and you should be able to identify these. All right, let's talk a little bit about pharyngeal innervation, okay? So a couple nerves that you're going to need to know, the glossopharyngeal, the vagus, and the spinal accessory nerves. So they share nuclei in the medulla. They provide sensory and motor innervation to the pharynx, the larynx, and the soft palate. The trigeminal nerve branches. They also contribute to the nasal cavity innervation. And this is a fairly complex site of innervation, so it's very important that you look at these diagrams, that you study them, and truthfully, if you draw it out, I think that's the best way to do it. Draw it to know it, trace it out, label it. You do that a couple times, you're going to feel a lot better with it. So airway reflexes like the gag reflex protect against aspiration. So when you think about your sensory function, sensory stimuli from the posterior pharynx are carried by the glossopharyngeal nerve to the medulla. They synapse with the vagus nerve and the accessory nerve. Motor responses are primarily through the vagus nerve. That's going to help to elevate and constrict your pharyngeal muscles during swallowing, gag reflex activation, ensuring airway protection. You should be able to identify your glossopharyngeal, your vagus, your spinal accessory nerves. Okay? The trigeminal nerve innervates the nasal cavity, and the gag reflex helps to protect the airway from aspiration. If somebody is paralyzed, okay, somebody is paralyzed, are they going to have a gag reflex? No, they're not. Okay? So if you have somebody very, very light, okay, say you, for some reason, you have somebody on half a mac of gas, all right, it's not very, very deep, fairly light, and you give them a profound reversal with 500 of Sugamidex. What is the risk of doing that? Okay, maybe aspiration. Think more so if somebody is that light and they're paralyzed, their vocal cords are probably wide open. Say they have an LMA, okay, or say that you're wanting to get them back breathing. All right, if you have somebody very, very light and then you reverse them, all right, their body may have been sending the signals to spasm, 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 okay, because they're that light but they're paralyzed. All right, the moment you reverse them, they take a couple breaths, you pull that tube, all of a sudden they have a laryngospasm. Okay, so profound reversal from deep paralysis and a light anesthetic equal a laryngospasm. Okay, what are signs and symptoms of a laryngospasm? Okay, all right, so when you think laryngospasm, okay, and your vocal cords are closed, are you going to get any end-tidal CO2? Okay, you're not going to get anything, all right? And say you extubate them, you close your APL valve, so you're giving some positive pressure, and whenever you squeeze that bag, all right, is anything going into the lungs? No. Okay, so what's happening? Where's all that air going? Stomach. Okay, is that good? No. How do you break a laryngospasm? Say that again. Okay, Larson's maneuver. Okay, so Larson's maneuver, so pressure on the angle of the mandible, fairly hard. Okay, say it doesn't break. What next? Okay, 100% FiO2. What are some ways you can deepen your anesthetic? Okay, what else could you do? Yeah, you can turn your gas back on. Okay, if that doesn't work, what is the 100% surefire fix of a laryngospasm? Sucks. How much?
16.
Are you giving it
IV. They've got an IV. What's your laryngospasm dose? Hold on, somebody said it. It's like yeah, it's very, very small. It's like 0.1 milligram per kilo. A half to 1 cc of succinylcholine. Succinylcholine is 20 milligrams per ml. So 10 to 20 milligrams is enough to break a laryngospasm in an adult. Okay? So I had a case the other day, and it was so interesting. Older lady, she's like 86 years old, so truthfully not somebody who's at risk of a laryngospasm. She doesn't have any airway irritability, but she does have a lot of secretions. So we're finishing up a shoulder surgery. I reversed her, suctioned her out. She has an oral airway in. And I take out the ET tube while she's still in the sitting position, and I'm holding the mask, and she takes a couple breaths, and then she starts to cough, and then and then nothing. All right, so my first thing is, okay, give her some positive pressure. All right, that's not doing anything. All right, and this is how I normally troubleshoot a laryngospasm. I give myself 30 seconds or desaturation. So at most, I'm going to mess with it for 30 seconds. Okay, if I've not broken it with positive pressure or Larson's or anything like that, I'm going to go ahead and fix it. All right, so I did positive pressure. I'm not a big fan of deepening the anesthetic because, truthfully, laryngospasms happen because somebody's light. You deepen the anesthetic, you still have to bring them back through stage 2 again. So your odds of having another spasm, they're higher than normal. Okay, so 30 seconds, it's not broken. She's still satting 99%. Okay, but tried to mask her, can't, dropped everything, turned around, grabbed sucks out of my cart, popped the cap on it, drew up half a cc. All right, went to her IV, pushed it in, went back. A half cc takes about 20 to 30 seconds to work. If you have somebody with slow circulation like her, a cc, somebody with quicker circulation, it'll be like 10 seconds to fix it. All right, her sat stayed 99%, immediately broke. And You can read in the textbook, Nagel how it mentions it, but with that small of a dose of succinylcholine, choline, people will come back spontaneously ventilating fairly quickly, especially if they were ventilating before. All right? So laryngospasm's fixed. She's back ventilating. We go to PACU. No negative sequelae. What happens if I don't fix that? What can happen from a laryngospasm? If somebody's breathing in that closed glottis. Yeah, negative pressure pulmonary edema. Sometimes they'll call that obstructive pulmonary edema. All right, and what's that from? I think I said it. Breathing against that closed glottis. It'd be the same as putting your hand over your mouth and as hard as you can taking a very, very deep breath. Okay, because that's what they're doing. They're trying to generate a large tidal volume against a closed glottis. How many breaths of that does it take to get negative pressure pulmonary edema? Somebody really, really big and strong who can take a large breath? One tidal volume breath. That's all it takes. Okay? What happens when somebody gets negative pressure pulmonary edema? Say that again? Okay, swelling. All right. All right, so capillary leakage. Okay? And it's going to sound like if you go to listen to them, all right, they're going to sound crackly. All right? They're not going to maintain their SATs. All right? You will either have to put them on some form of CPAP or BiPAP or intubate them if it's fairly severe. They're probably going to get admitted or at least stay for a good 8 to 12 hours of observation. Okay? What are some signs and symptoms of negative pressure pulmonary edema? Boom. Right. Okay? So if they start coughing, okay, and they cough that up and they say, I can't breathe, or you hear almost crackles when they're breathing, all right, you didn't treat the spasm quick enough. That's why it happens. When you see patients that aren't satting well in PACU, okay, and it's not an adequate reversal, it's not, you've troubleshot things, all right, pull up the anesthesia record. Okay, if you haven't, and this is why I love electronic records. You can't hide a shitty anesthetic if you're using electronic records. Everything ports over, all right? If you see somebody that's not satting well, that should be, that, it doesn't sound quite right, you pull up their anesthesia record and you see that sat, whoop, whoop, right there at the end. They obstructed, they desaturated, their spasm was not fixed, and they have some probably mild form of negative pressure pulmonary edema. All right, that's pretty serious. Like I said, CPAP or BiPAP. You get somebody elderly, they'll stay the night in the hospital. That's about a $10,000 to $15,000 stay, probably more. All right, somebody younger. If you're not used to wearing CPAP, and I made everybody in here wear CPAP for the next 8 hours, how miserable are you going to feel? Okay, right. So what's the What's the downside of giving succinylcholine? What's everybody's fear of giving a half cc or a cc of succ to fix a spasm? Yeah, maybe they have pseudocholinesterase deficiency. Okay, what are the odds of pseudocholinesterase deficiency? Okay, so there's heterozygous and homozygous. Homozygous is like 1 in 2 to 5,000. Heterozygous is like 1 in 500. Okay, all right. I'm gonna roll my dice every single time on the 99.8% chance that it's gonna be just fine. Okay, because it probably is, but you're fixing the spasm. Now, if you don't fix it and you get negative pressure pulmonary edema, it's probably a 1 in 2 chance that patient's going to stay in the hospital that night. Those aren't good odds, okay? So fix your laryngospasms. Yes? Say that again.
If you encounter a patient with a known pseudocholinesterase deficiency, what are your options there?
Yep, 10 milligrams of rocuronium. If you've given Sugamidex, what happens though? Yeah, if you've given Sugamidex, you either have to use Nimbex or cisatracurium, okay? Or rock's probably not going to fix it, then you're going to have to deepen it. So known pseudocholinesterase deficiency is probably pretty rare, but worst case scenario, say they're still spasming, you can't break it, Nimbex is in the refrigerator in the Pyxis in the med room, you can give sucks, and guess what? You'd have to leave them sedated, okay, for a little bit. All right, and truthfully, 10 to 20 milligrams of sucks is not going to, even with pseudocholinesterase deficiency, it's not like a RSI dose. It may be a little bit longer, but if you've already reversed with Sugamidex, then you're kind of hosed. It's a crappy situation. Somebody else raise their hand? Go ahead.
In that situation where you give the 10 to 20 to break the laryngospasm, are they coming back ventilating on their own that quickly, or are you having to mask them temporarily?
So normally what will happen is after you give it, you'll go back to holding positive pressure, okay? And if you're keeping your hand on the back, you'll feel when the vocal cords open. And normally what I'll do is give them a couple breaths, okay? Confirm I have end tidal, and then wait. And it fairly quickly. Literally within 2 minutes, we were walking out the door to pack you. All right. It is such a big deal, okay, in anesthesia to mitigate your risks, okay? 1 in like 10 to 15,000 ASA 1s will have a poor outcome, okay? ASA 2s, it's like 1 in 5,000. ASA 3s, 1 in 500 to 1,000. ASA 4s, it's like 1 in 50. ASA 5s, probably 1 in 10. All right?
I remember those numbers.
I don't know, something's wrong with me, obviously. I'm so impressed by numbers. Like, that just blows my mind. But mitigate your risks, okay? You want to be oh so cautious. You want to treat your patients and do exactly what you would want done for yourself or a loved one. You don't want someone rolling those dice with, okay, hey, maybe you'll stay the night in the hospital tonight. Or if you have somebody who's really, really sick and has a bad heart, okay, all right, they can get bradycardic, all right? They can need epi. They can need CPR from a laryngospasm that kills people. All right, fix it quickly. Okay, think about, and we'll go about 2 more minutes and then take a little break. So think about your superior laryngeal nerve. So that's going to branch off the vagus nerve. You're going to have your internal and external branches. Your internal will give sensory input to the hypopharynx above the vocal cords, like the tongue, the epiglottis, the air epiglottic folds, okay, and the arytenoids. The external branch is going to be motor innervation to the cricothyroid muscle, and that's going to play a role in your pitch modulation by tensing your vocal cords. Then you have your recurrent laryngeal nerve, okay? Why is it called the recurrent laryngeal nerve? Yeah, because it wraps around. It's recurrent, okay? It provides sensory innervation here, right there. Whoop, wraps around. Okay, it provides sensory innervation to the subglottic region and the trachea. Its motor component supplies all the intrinsic muscles of the larynx except the cricothyroid. Its looping path around major arteries like that right subclavian, the aortic arch on the left, makes it vulnerable during thoracic surgeries where tracheal traction can lead to hoarseness, stridor, and respiratory distress. What would be some cases where you would see traction on either the right subclavian or the aortic arch?
Cardiac case.
Yeah, cabbage. Okay. So swallowing problems post-cabbage, it's actually higher than you think. ACDFs, okay, so if you're putting in a big cervical retractor and you're a little lower, all right, you can have recurrent laryngeal nerve pressure. In addition to that, another big one that you guys will learn about a lot is a mediastinoscopy. Have you guys ever heard about that, seen those, talked about them? Okay, so it basically looks like a large Miller laryngoscope, except they make an incision here into the mediastinum and are going in between the tissues to take a biopsy of the lymph nodes. Okay, vascular and thoracic surgeons, CT surgeons, it's more of an old school thing. You'll see some do them. Bronchoscopy with EVIS is typically the better way to get a biopsy now. But recurrent laryngeal nerve injury, okay, subclavian artery compression, fairly common whenever those were, done more often. So keep in mind, know your nerve innervation. Whenever you think about vocal cord paralysis, okay, say from a thyroid surgery, all right, we're normally assessing our patients preoperatively. We're normally assessing them for any swallowing difficulties. If they're having any stridor or breathing problems in PACU, you automatically want to think recurrent laryngeal nerve injury. What kind of ET tube do we use for a thyroid surgery?
NIMS.
Okay, what's that? Do you know what that stands for?
It's a nerve. It's
Mhm.
a nerve monitoring.
Yeah,
tube.
nerve integrity monitoring tube. Okay, the majority of your NIMS tubes, all right, they're going to come in a big box. They're going to have 2 sets of needles in there that you're going to take out and probably save in case they want them. Sometimes they don't. And then on your cuff, you're going to have a couple areas. You're going to have a white area and a blue area. You're going to want to have it blue between the cords. Okay. Some places I've seen surgeons are real picky and they want to watch you physically have your glide scope there. They want to know where the tube is. I feel like if any surgeon's doing that, they're probably looking for somebody to blame because they've had problems. I mean, whenever we worked with Weirson, Chambers, and Hasse, or some of our general surgeons, that's never a thing. I never used a video scope. It was put the tube in. All right. ENT surgeons normally take quite a bit on thyroids. Okay, so if you ever see an ENT surgeon doing a total thyroidectomy or partial, it's going to take forever. Normally, your general surgeons are a lot quicker. Okay. I will say though, the majority of nerve injuries I've seen have been from general surgeons because they are a lot quicker with it. So no things like that. With your NIMS tubes, if you read in the package insert, you're not supposed to put any lidocaine on the cuff. You're not supposed to spray the vocal cords with any local anesthetic, even though historically that's been done in the clinical setting for years. All right, like literally I grew up trained to do that. That's what we did. And I'll never forget, I was at a rotation, and they're like, oh, have you ever read the package insert for that? No, never have. All right, you should probably read it. Because I suggested, oh, let's do an LTA. It literally says in big words there. And also, NIMS tubes are not meant for prolonged post-op ventilation. So if you place one for a case and that patient stays intubated, like say you're doing a big spine case, you need to exchange that tube out. Literally says it's not meant for post-op ventilation. So another thing with NIMS tubes. Okay. Anatomical path of the recurrent laryngeal. It loops around those major vascular structures like the right subclavian. On the left, you have the aortic arch before it ascends towards the larynx. You're going to have sensory innervation to the subglottic area, motor innervation to all the intrinsic laryngeal muscles except the cricothyroid muscle. And that's innervated by the external branch of the superior laryngeal nerve. The recurrent laryngeal is especially susceptible to damage during those large cases like thyroidectomy, cardiovascular procedures, because there's traction on that nerve. Okay, this can lead to hoarseness, which is going to be more of a unilateral injury. Okay, if you have somebody who is having trouble breathing or trouble maintaining their saturations, it's probably a bilateral injury. Okay, hopefully that's rare. Early recognition is critical for preventing respiratory complications. All right. So both the injury risk and consequences, both the superior laryngeal and the recurrent laryngeal are susceptible to those high injuries, okay? The left is especially vulnerable when you have compression from aortic arch aneurysms, okay? Mitral stenosis can lead to hoarseness. Unilateral recurrent laryngeal injury causes that hoarseness without compromising the respiration. So, and normally after a thyroid surgery, normally after ACDFs, patients are a little hoarse, okay? But afterwards, okay, if they're still talking very quietly, or I don't know why I'm talking like this, what do? Call ENT. Now, if you want to take a look at their vocal cords, what can you do? You can literally take a video scope, all right, have them open up their mouth, stick out their tongue, and honestly, just having it in the posterior oropharynx, you can get a look, or you can anesthetize in air and slide it down and look at their vocal cords. But honestly, have ENT do it. That's the easiest thing to do. So, unilateral, like I said, the hoarseness. Bilateral, okay, that can be vocal cord adduction that will cause stridor and life-threatening respiratory distress. If you have stridor post-operative and you give some racemic epi and that doesn't fix it, and you've been in one of these big cases, it's probably a vocal cord injury. Chronic recurrent laryngeal nerve injury can develop compensatory mechanisms, all right? Some of these patients will tell you, oh, I have a chronic vocal cord injury, and they have chronic issues afterwards, but they can develop some type of compensatory mechanism where they can still talk. They may not have to have a trach or anything like that. They normally have changes in their voice, okay? Superior laryngeal nerve injuries are less likely to cause respiratory distress, but can impair vocal modulation due to loss of cricothyroid function. So this is, I think, a great example for patients who are really, really worried about their voice. So you may occasionally have patients who are singers, who are either in choir groups. I took care of a lady, ironically, was an opera singer, okay? And such a weird thing. Literally, whenever I walk in, and I'm like, oh, well, I'm Matthew with anesthesia. She's like, oh my gosh, I've been waiting to talk to you. She's like, I am so worried that my voice is going to be messed up. I'm like, oh, why is that? We had this long discussion, and she was having a laparoscopic case, and this is, I think, the one time I've done an LMA in laparoscopy. We talked about it. She's adequately NPO. It was everything to avoid tracheal intubation, okay, because she was so worried about her voice. That's how she made her living, all right? That was her big concern, all right? So I wound up doing an LMA for the case. worked out fine. She had no issues post-operatively. Took care of another guy, and talking to him in pre-op, it was an ENT case. It was fairly simple, and intubate him, and I'm in the OR, and the surgeon goes, "Oh, you're ballsy." What? It's Dr. Sims. And I'm like, why is that? He's like, you put an 8.0 tube in this guy. Yeah, so he's a big guy. He's like, did he tell you what he did? He told me he played some music down in Nashville. He's like, this guy just had an interview in Rolling Stones. He's a country singer. He's from Bowling Green. Has seen Dr. Sims his whole life. Came up for surgery. Yep. You talk about a holy moment. I quickly Googled because I'm like, I don't know what to do. I put lidocaine in his cuff. I took all the air out, replaced it with lidocaine to hopefully anesthetize it, monitored my cuff pressures, x-rayed him, he's fine. It was years ago. And I'll ask the guys, like, oh, like I'm making conversation. He's like, oh, I play a little music down in Nashville. I figured he strummed the guitar on the sidewalk. I'm like, okay, that's a nice way to say you're homeless. Like, oh, cool. Nope, not at all. So whenever you're caring for patients and you're coming up with your anesthetic care plans, tailor them to your patient's needs. Work with them, explain to them risks versus benefits, all right? Whenever I'm talking to this lady who's so worried about her vocal cord, the risk of aspiration, okay, was probably smaller than her having a vocal cord injury or changes, all right, because she is so sensitive. So those are things you can do to help you mitigate your risks. All right, get through the next 2 slides. So just looking at your pathway of your vagus nerves and your superior and recurrent laryngeal nerves, pay very close attention to these structures, all right? You can look up some gross anatomy pictures, and I think they're very handy. They're great to visualize, because it's one thing to see, an anatomical drawing that someone else has done, but if you can become familiar and think about what that nerve compression would look like, you can see your part of your laryngeal nerve there, and you can see your effects of vocal cord dysfunction. So unilateral recurrent laryngeal nerve injury can cause one vocal cord to assume a paramedian position, resulting in hoarseness, preserving respiratory function. Bilateral can lead to both vocal cords having adduction, okay? That will cause stridor, potential airway obstruction, and that can necessitate an emergent treatment. I think a tracheostomy is incredibly rare for something like that, but that is talked about in the literature. If you have somebody who has a chronic nerve injury, all right, you may have trouble breathing, changes in your speech, but as long as it's not an acute injury, you're probably going to be just fine. You still want to be very gentle whenever you intubate these people. And things that you can do to help mitigate your risks: smaller ET tube size, monitor your airway pressures, your cuff pressures as well, and prevent any additional traction. And if you're doing a case, like say even a cervical, say a ACDF, so you're doing a cervical surgery, even if they're not using a NIMS tube, you can hook up and you can monitor your cuff pressures, and you'd be surprised when that airway retractor goes in, or that retractor goes in, your airway pressures on your cuff will be 70 or 80. All right, they should be 20 to 30. So I normally do continuous manometry in those cases. All right. Okay, so the larynx consists of 3 single cartilages: thyroid, cricoid, and your epiglottis, and your 3 paired cartilages: your arytenoid, your corniculate, and your cuneiform, along with your intrinsic and extrinsic muscles. These structures help protect the lower airway. They facilitate breathing. They enable phonation. And the cricoid cartilage, and we talked about this, is the only complete ring, and that provides that structural integrity. Okay, so the larynx, the primary role is preventing aspiration, maintaining patency, and supporting protective reflexes like coughing. The intrinsic muscles are innervated by the recurrent laryngeal, which is going to control that vocal cord movement, while the cricoid thyroid muscles has superior laryngeal nerve innervation. That adjusts the tension, okay, for vocal modulation. The larynx spans from the 3rd to the 6th cervical vertebrae, bridging the hypopharynx and the trachea. All right, you should be able to label this. All right, these are the intrinsic muscles. Okay, Nagelhout has some really good acronyms. Your posterior cricoarytenoids pull cords apart. Lateral cricoarytenoids, let's close the airways. Your So however you want to learn them, I do think the acronyms are very helpful, but whatever works for you, but you have to know them. Most intrinsic laryngeal muscles are innervated by the recurrent laryngeal with the exception of the cricothyroid, and that receives innervation from the external branch of the superior laryngeal nerve. Proper function of these muscles is critical for maintaining airway patency, phonation, and your airway protection. All right, you should know this table. That's from Nagelhout. Okay, cartilages of the larynx. Just briefly going over these again. Your single cartilages, thyroid, cricoid, your epiglottis. Your paired, your arytenoid, corniculate, or your cuneiform cartilages. The cricoid cartilage is unique as it's the only complete ring. Okay, that provides structural integrity. Okay, so cricoid pressure, you should know where to give it. You should know where your cricothyroid membrane is. You should be able to identify all of those. When you think about your muscle attachment, your extrinsic muscles anchor the larynx to the surrounding structures. Okay, while your intrinsic muscles control your vocal cord movements, and they work synergistically with the cartilages to protect the airway, regulate airflow, and produce sound. You need to know this. All right, and then this is just your anterior and posterior views. So when you think about the anterior view of the larynx, you're going to see the thyroid cartilage, cricoid cartilage, your cricothyroid membrane. Okay, the thyroid cartilage is that prominent feature. The laryngeal prominence or Adam's apple is normally visible. The cricoid cartilage will be inferior, and it's the only complete ring, 360-degree coverage. All right, everything else, 270. Posterior view, okay, you have your paired arytenoid and your corniculate cartilages. Normally, whenever you are intubating somebody and you think you see the arytenoids, okay, it's actually the corniculate cartilage, okay. Apex points that out, but when you start doing this, you'll actually notice, like, okay, those aren't the arytenoids. Okay, and sometimes you'll see your air epiglottic folds, but normally it's your corniculate cartilage. All right, posteriorly, those air epiglottic folds and your muscular attachments support airway patency and your vocal cord functioning. You have ligaments, okay, that are associated with that cricothyroid joint, and they play a significant role in vocal cord tensing and pitch modulation. Okay, now let's talk about the trachea. You should know where your cricothyroid membrane is. Okay, you have to know this. So the trachea extends from the cricoid cartilage to the carina. It's approximately 10 to 20 centimeters in length in adults. You should know that. So if you are intubating an adult and you see your cuff pass the vocal cords, what's the ideal position of the tip of the endotracheal tube? Yeah. Yeah, 4 to 6, depending on who you ask, where you ask. You don't want it at the carina. Okay, if it's at the carina, they're going to be irritated, they're going to cough, but you don't want it in the right main stem. Okay, pay very close attention to that. You also don't want it right past the vocal cords. Now, in kids, okay, think about your vocal cord to carina distance. It's much smaller. Okay, so with kids, it's very important to know exactly where your tube is. With adults, 21 to 23 is probably good in most adults. Okay, 21 for women, 23 for men. You will be surprised. I have literally done a right main stem intubation with an ET tube at 21 centimeters in a 5 foot tall female. I'm like, there's no way I'm right main stem. I refuse to believe it. I grabbed a scope, scoped her. I pulled it back to 17. All right, that's like pediatric size. Don't know why. She didn't look abnormal, nothing. It was just a very small airway. So pay very close attention to that. So how can you tell if you are right main stemmed? Okay, exactly. All right, so that's a pretty good indicator. What about your peak airway pressures? They're going to be higher. Okay, and then hopefully you notice it sooner rather than later. Sometimes it can happen with positioning changes. Okay, the hose follows the nose, so if you are extending the head, all right, it's going to you're more likely to get a supraglottic cuff. Okay, and if you are say you're either changing bed positions, if you anchor the head down, you're more likely to get a right main stem intubation. Keep that in mind when you're thinking about positioning changes. At the end of the day, okay, identifying a right main stem intubation is so much better to do it immediately post-intubation than 20 minutes inside the case where you've slowly desaturated and now you're having a precipitous drop. What's the downside to, if you notice it then, what are you more likely to have built up now that that left lung has not been ventilated for 15 to 20 minutes? Atelectasis, how's it going to manifest? You're not going to saturate well, okay? Your patient is going to struggle to breathe post-operatively, okay? Depending on the type of surgery they have, they may really, really have issues. And they're at greater risk of respiratory complications for the next 24 to 48 hours, all right? Because you've literally not ventilated that long. In kids, it's really easy to do a right main stem intubation. Pay very close attention. And wherever you tape the tube, like wherever you tape around the tube, that's where it's going to stay in place. So you bring tape across the face, okay, and your ET tube sticking out like this, and you loop it around 2 or 3 centimeters above, then you place it down. You'll notice after about 15 or 20 minutes, that tube will have came down and your tape will be right here. So wherever you want that tube, put your tape. Pay very close attention to that. Okay? What is this structure marked with the X? Okay. All right, your carina. This, I think, is a really, really good image here. Okay, the one on the left. Because you can see those rings. All right, and you can identify whether or not you are anterior or posterior. So whenever you're doing, say, a double lumen tube, orienting yourself is like 80% of things. All right. So with your double lumen tube, you want to know exactly where you're at. Don't get confused. You know, sometimes you can be actually down the right main stem already, and you'll be like, oh man, where's the carina? And you have to back out. So with bronchoscopy, this is an essential skill, but orienting yourself, it's a huge part of it. So that's where practicing with the ORSIM is so good. I mean, truthfully, that's the best form of practice with the fiber optic scope. I mean, I can't think of anything better. All right, so a couple things about the diaphragm. So with the diaphragm, it receives innervation from the phrenic nerve, C3 to C5, and it travels through the pericardium. This innervation allows for coordinated contraction during respiration. You can have congenital anomalies that we'll learn about with diaphragmatic hernias that may result from improper development. This can lead to respiratory compromise at birth, okay? Know that it's innervated by the phrenic nerve. What's so specific about that nerve and, say, regional anesthesia? Yeah, so if you do a brachial plexus, you're always going to get what? Probably some phrenic involvement, okay? And that's going to create some breathing difficulties. Now, what if we accidentally block the wrong side? Can we go ahead and block the other side? What will end up happening? Diaphragmatic paralysis, yeah. It's not going to be good. If that happens, you should take the needle away from that person. That's a no-no. Okay. The diaphragm is a critical respiratory muscle. All right, you need to know that. Here's a couple good pictures. The abdominal surface of the diaphragm here in that cadaver. You have the esophageal hiatus that's going to pass through the right crust of the diaphragm. The foramen of the inferior vena cava also traverses through that central tendon. And you have your aortic hiatus, which is going to be actually passing behind the diaphragm. Okay. Anatomically, you can define the hiatus as that opening, okay, that gap that allows those structures to pass. And we have, like I said, the inferior vena cava, the esophagus, the vagus nerves, and descending aorta, along with some other structures. An easy way to remember that, okay, I ate 10 eggs at 12. The IVC crosses the diaphragm at T8. 10 eggs, so that's your esophageal, your vagus at the level of T10. At 12, okay, that's your aorta, your thoracic duct at T12. So I ate 10 eggs at 12. I hate eggs, so it's scarred me. I never want you to admit to eating eggs. All right, key indicators of difficult airways. Okay, length of upper incisors. These are some predictors of the difficult airway. When you see these things, this is when you should start going, all right, and you start shaping your plan. Relatively long upper incisors, prominent maxillary overbite. The inability to protrude your mandibular incisors during jaw movement. If you can't do that, a short inner incisor distance, limited visibility of the uvula, so a Mallampati 3 or 4. Okay, a short or thick neck. Okay, non-compliant mandibular space, a thyromental distance less than 3 finger breadths, limited head and neck mobility, arthritis, trauma, unstable C-spine. They're already in a C collar. Okay, if you notice these things, all right, this is when you should start planning for a video laryngoscopy or fiber optic intubation. Okay, what's the advantage of fiber optic intubation versus video laryngoscopy? Or whenever I say AFOI, what does the A stand for? Awake. What does that mean that patient's probably doing? Breathing. Okay, so the safest thing to do is to keep your patient breathing. All right, AFOI, awake fiber optic. Now you can probably smear some lidocaine jelly on a video scope and shove it in somebody's mouth. I've seen that done before. It's not very smooth, not at all. People don't like it. You should know how to assess your modified Mallampati classification. Look at your neighbor, okay? Find out what their Mallampati score is, okay? Seriously. Do an assessment on one another. Hold on. Are you supposed to phonate?
No.
How many ahs did I hear? A lot of them. Okay. So do me a favor. Did anybody have like a class 3 or 4? Any of the guys? Okay. It's okay if you did. Perfect. Okay. So look in his airway again. All right. Look in your neighbor's airway again. Okay. And do this. Okay. Open up, and then take a deep breath in, and you'll see structures change. Okay. Yeah, you should be able to see the uvula. So that's movement of the soft palate. Okay, if you have a poor view, have them open up their mouth, take a deep breath in. Okay, if you still don't see structures change, that's another indicator of this is going to be a difficult airway. All right, and then if you see somebody with a class 3 or 4 airway, what are some follow-up questions? Do you have sleep apnea? Do you snore? Okay, do you use a CPAP machine? Sometimes you have to ask things in a different way, because some people, do you snore? I don't know. No one ever complains. All right. Do you have sleep apnea? Yes. But do they use a CPAP machine? No. So asking and being aware of that. You should know and be able to identify hard palate, soft palate, tonsillar pillars, the uvula. You're going to do this thousands, tens of thousands of times in your career. Okay? There is that modified Mallampati test. The big thing is knowing that the Mallampati is not the be-all, end-all. This is a great way to find the unanticipated difficult airway if you're solely relying on this, okay? Because you will occasionally have a class 1 or class 2 who is hard to intubate, and that's very, very frustrating, all right? But at the same time, you'll also have people who have a class 4 airway who, once you get in the OR and you go to look, you have a grade 1 view. So it's not the be-all, end-all, but it is a good predictor. Okay, the 3-3-2 assessment, okay? So this is a bedside evaluation. Okay, you want to look at mouth opening greater than or equal to 3 finger breadths, your thyromental distance, and the distance from the thyroid notch to the hyoid bone. Okay, that's your 2. This is a very quick and effective way to identify patients who are at risk for difficult intubation. So if you have a poor Mallampati score, you can do the full 3-3-2. You can normally, with a look test, you can see who has a short thyromental distance. Okay, if you're using electronic charting, okay, and you're used to going through and clicking things, full range of motion greater than 3 finger breadths for thyromental distance, pay very close attention to how you chart NPs. Very rarely is a pediatric airway greater than 3 finger breadths, okay? Pay very close attention to that. I see that all the time done on charting. I'm like, nope, that is inaccurate. So, but the full 3-3-2, looking at the thyroid notch to the hyoid bone, not done as often. So, difficulty with bag mask ventilation, okay? Facial hair, upper airway obstruction, reduced upper airway tissue elasticity, so in older adults, okay? These can complement mask seal and ventilation. Obesity, someone who is edentulous, okay? Conditions that reduce lung compliance. Think somebody with pulmonary fibrosis or emphysema, all right? A difficulty with direct laryngoscopy and intubation. You may have a class 3 or 4 airway, a short thyromental distance, neck scarring, okay, so neck radiation, a radical neck dissection, limited C-spine mobility, a large neck circumference, okay? This can correlate with difficult visualization of the vocal cords, necessitating advanced equipment like video laryngoscopes, okay? So if you have somebody who has 3 or 4 of these predictors, you should have plan A, B, and C, okay? You should have a video scope in the room, all right? There's no excuse today to not have one in the room if you have someone that you're anticipating to be a challenging airway or you feel that you may have trouble masking them, okay? And then you should have, and this is a me thing, but I'm a big fan of it. I always have an LMA on the back of my cart because, like, that's your rescue. That's a better oral airway. I always have an LMA out to where I can grab it. Now, when it comes to preparing for these types of cases, you need to know, like if you see somebody with neck scarring, radiation, okay, if they already have a very, very soft voice, okay, and you can hear them breathing from down the hallway because they're struggling, that's a big red flag, okay? You should be able to go in and tell who's going to be difficult, okay, and who's going to probably be okay. Difficulty with supraglottic airway placement, okay, restricted mouth opening. Somebody with a restricted mouth opening, all right, so small, all right, you might not be able to place a videoscope or you might not be able to place an ET tube. Okay, upper airway obstruction, distortion of airway anatomy, all right, increases in airway resistance, pulmonary compliance issues. And then somebody who might be a difficult cricothyrotomy. So if you have somebody who has distorted neck anatomy, a hematoma, say they have a post-op thyroid bleed, and they have a huge hematoma right here, okay? Post-op carotid bleeds, all right, those are challenging airways, but normally they're just going to deviate the airway, okay, right or left, all right? A post-op thyroid bleed is going to compress the airway. Those are a lot more dangerous. Those are ones that if it's really bad, I'm going to intubate them and pack you. I'm not gonna wait 15 minutes to take them to the OR. We're gonna go ahead and get them intubated now. Okay, supraglottic airway placement is your rescue. Okay, so if you cannot ventilate somebody, you're normally grabbing an LMA. But if you cannot get that to place, that's whenever you start to worry. That's whenever you start to panic. All right. The number one thing, and we'll talk about this when we get to the difficult airway algorithm, if you have trouble intubating somebody with your first view, your first look, the first thing you should do is call for help. Can I get a second set of hands? That's all I have to say. It's not hit anesthesia stat emergency. Can I get a second set of hands? All right. Now, if you're in a room by yourself and you're the only CRNA in that facility, that second set of hands could be the surgeon. That could be somebody else in that room. Because oftentimes it's only the nurse who's standing up by you during intubation. But having somebody else around. So those are things you have to keep in mind. Ventilation difficulty can arise, and that is whenever things go really poorly. Because if you can ventilate somebody, you worry a lot less. You have to know what grade view you have. You will chart this, okay? You need to be familiar. If you can see your epiglottis, your complete opening, your vocal cords, all right, it's a grade 1 view. If you only see part of your vocal cords, if you only see the bottom of your glottis, or if you just see hard palate or soft palate. If you have a grade 4 view with any blade, you should probably immediately switch to a video laryngoscope. And if you have a grade 4 view with a video laryngoscope, it is probably a positioning problem, okay? That's repositioning not only the blade, but the patient as well. Whenever you guys are in the OR with me, one thing that I harp on students again and again is to get patients in a good sniffing position, all right? If we're in the OR minus the cysto room and I can move the table, I have their back up, I have their neck extended, okay? I hate seeing this, and I see people do this all the time, is they go to DL and then they lift the head up, okay? What happens when you lift the head up? How are you gonna put the tube in? You're gonna grab it with your teeth? No, you have to move this hand. Now who's holding the head? Oh, have your nurse do that? No, you shouldn't be doing that. And also, like cranking back on the neck, you'd be surprised at how many people have C-spine instability or some cervical compression that you could potentially make worse. There have been cases where patients have woken up, okay, with cervical neck injuries from poor intubation, okay? So cranking back on that neck, very dangerous. Try not to get in the habit. Have somebody in a good position. If they can extend their neck, ask them before they go to sleep, oh, are you comfortable like that? Yep, perfect.
Dr. Herman,
Yes.
this 2ATD stuff, like, should we care about that?
I think you should be somewhat familiar with it, but most people are going to say grade 2, grade 3. Okay. Things that make you go, All right, congenital and acquired conditions associated with a difficult airway. Okay. You should be familiar with these. Pierre-Robin, Treacher-Collins, Down syndrome. Okay. Pierre-Robin, okay, they're micrognathic. All right, this could lead to airway obstruction. Treacher-Collins, they have mandibular and zygomatic hypoplasia. So they have reduced facial structures, and sometimes these people have had facial reconstructive surgery to where you might not know it just off of a quick look, but then you look at them a little longer and you can see scarring. Down syndrome, macroglossia, subglottic stenosis, atlantoaxial instability. What is that? C1, C2 instability. Okay, so cranking back on their head, okay, that's a no-no. Do not do that. All right. If you have somebody who has macroglossia, subglottic stenosis, atlantoaxial instability, these create challenges. Okay, how should you handle this? Okay, probably a video scope. I would say there's probably very little reason to ever do direct laryngoscopy on somebody with Down syndrome. Okay, especially nowadays, it's not worth the risk. Have I done it before? Yes. Should you do it? Probably not. Okay, there are some acquired conditions that present additional challenges: morbid obesity. Okay, Ludwig's angina. Okay, that's going to be mouth and hypopharynx swelling, typically from a dental abscess. You're going to see those pictures in your textbook. All right, that's a big red flag. Okay. And here, golden Haar and Klippelfehl. So those are some other congenital abnormalities. Golden Haar, so that's going to be your hemifacial microsomia, vertebral anomalies, and that can create a very challenging chance for mask ventilation. Klippelfehl, so you have that cervical vertebral fusion, okay? So they're not moving that neck, okay, restricted neck mobility, and that makes intubation very, very challenging, okay? Planning for an awake intubation on some of these people will be very, very difficult. Normally it's going to be somewhat sedated, all right? But early recognition and airway planning is crucial. Advanced imaging is nice. You should, and we'll talk about this in advanced assessment, but being able to review a CT scan and look at the airway, that's huge. Okay, and knowing how to tell who's going to be difficult, who's not. If you see any of these facial abnormalities, these should make you go, hold on, stop. Do we need to intubate? Or if you're by yourself, can we get them somewhere else where you have lots of help? Go ahead.
What drugs do you use for fiber optic?
That's a great question. So you want to localize the airway, so you can do a lidocaine neb, you can do lidocaine jelly. There are some airway blocks you can do, but I find most of the time nebulized lidocaine is great. Follow up, you can use glycopyrrolate to help dry the mouth, and then Presidex to have them somewhat sedated and sleepy. Zofran reduces coughing and gagging as well. But whenever we talk neuro, I'll give you guys a very good breakdown on how I do my AFOIs. And then there's also a difference between awake and sedated. Because some people you can sedate and keep them breathing, but if you have somebody who's very, very challenging, you're going to be minimal, if any, sedation. Okay, and those acquired conditions, yes?
Any of the ones that have like the cervical vertebrae like abnormalities, are those the ones that like you would never like
Yeah,
flex their head back?
right, yes.
Okay.
Now, granted, I will say, with those, you probably want to do everything you can to avoid intubating them or taking away their ability to breathe. If they're ventilating themselves, now if they come in and they're, coding, that's completely different. But these are people that you don't you don't want to electively intubate. All right, and if they have these abnormalities, you should have a second provider there. Ideally, they should, if they're a pediatric patient, they should be done at a pediatric hospital. Okay. Yes.
If I remembering correctly, can nebulized lido cause bronchoconstriction?
I think it can be irritating, but I don't. That's not one that pops out of my mind. Alex. nebulized lidocaine and bronchoconstriction. That might be it might be mentioned, but it's not clinically. I haven't seen it because normally if you're doing an AFOI, you're going to have to anesthetize the airway somehow. And most people, airway blocks I feel like are such an old school thing.
Yeah, it's probably like more like textbook information than the data, so
Yeah.
probably their answer you wouldn't choose.
All right, a few things for acquired acromegaly, so macroglossia. All right, vocal cord swelling. I mentioned the Ludwig's angina, okay, and dental abscesses. Those are very frustrating because sometimes you'll have to do a nasal intubation or an oral intubation, and those patients have typically presented to the ER once or twice. They got antibiotics. It healed up somewhat. They never went to the dentist, and they come back and all of a sudden it's swollen. Rheumatoid arthritis, ankylosing spondylitis. These can all limit cervical spine mobility. Once again, do not crank back on that neck. Tumors, hemorrhage, trauma. These all necessitate advanced airway strategies. Being very, very careful. Risk assessment is huge. Careful planning. All right, making sure you have plan A, B, and C. Bag mask ventilation assessment. Okay, effective bag mask ventilation requires a good seal between the mask and the patient's face. I mentioned facial hair earlier, facial trauma, abnormal anatomy. Okay, you can do a C-clamp, E-clamp, two-hand mask, however you do it. Okay, so what are some strategies if somebody has a lot of facial hair? What can you do? You can shave them. Probably not be ideal. Yeah, you can do tegaderms. You can do lube. Go ahead. Yep. Yeah, you can do that. That is going to make it really sticky, but that will help that seal. And typically with those, two-hand mask. All right, that's whenever you want a second person in there helping you. Now, when it comes to getting them in the sniffing position, optimizing that airway patency, that's going to help your ventilation become more effective. Obesity, craniofacial abnormalities, limited neck mobility. Okay, if you're doing ACDF, okay, so neck surgery on the C-spine, okay, you are probably going to do video laryngoscopy. You don't want to crank back on that neck. So many times, if you get in the habit of that, you're going to find yourself doing that. I saw someone do it one time, I'm like, what are you doing? Oh, yeah, oh, no. They're in a C-collar. You can't be doing that. If you have trouble ventilating somebody, what's the first thing you should do? Bingo. Airway adjunct. Oral airway, nasal airway. You still can't do it. What do? Reposition, yeah, I should have asked for help. Yep, help should already be on the way. All right. You could do an LMA. That's a better oral airway. Okay. Now, if you go to take a look and you don't see anything and now you've wasted some time and now you're desaturating, that's what you don't want to do. You want to optimize your ventilation before you go and intubate. Okay, because if you can't get your intubation, what are you going to do? Oh shit? Probably. So you want to make sure that you can ventilate people. Now I'm going to say this, and whenever you are in the clinical setting, do not paralyze somebody before you've attempted to ventilate them unless your preceptor tells you to. Okay, so if you're doing an RSI with rock, all right, and you give your drugs and then I see you messing with the airway, just go ahead and give your paralytic. Just go ahead and give your rock. Okay? But if 99% of people, especially when you're new, they want to know if you're safe. Safety is making sure you can ventilate. But what happens when you try to ventilate somebody and they're not paralyzed? How are their vocal cords? Probably not wide open. They're probably like this. They're probably going to be more difficult to ventilate. So when you paralyze somebody, your cords open up. And if you're inducing, say, with succinylcholine choline and you can't ventilate somebody, what are you going to do? You're going to give your sucks. So a lot of people will just say, well, go ahead and give your paralytic. However, for the most part, okay, unless your preceptor says so, ventilate before you intubate. Even if the research says this person says this, Dr. Harmon says this, Dr. Nagorny does this, doesn't matter. You're being safe. You guys are new in the OR. We want you safe. How to hold a mask. We can practice this here in just a little bit. I harp on people, Alex, for this. I don't like people starting off with like these weird hand positions because someone shows them. I think really, really try with, like you should do it textbook. Because, even I've seen people with really, really small hands still be able to mask somebody. But But then there's other ways to ventilate people as well. And at the end of the day, you're going to do what works good for you. So bag mask ventilation. This is crucial. This is what keeps somebody alive. Achieving an effective seal is essential. Okay, if you hear a leak, if you hear and you can see that you're not ventilating, or if you think you're ventilating well and you're not getting end-tidal CO2, are you ventilating? No. Unless something happened, because you should have checked your machine, you should have been pre-oxygenating, you should have seen end-tidal. It probably didn't break in the 30 seconds between pushing your drugs in now. Okay, so if you're squeezing the bag and you don't have end-tidal CO2, you're not getting it, you're not ventilating. You're just not. So optimize it. Okay, end-tidal CO2 is the gold standard. Okay, proper positioning, a jaw thrust maneuver, two-hand mask, fifth finger on the mandible, whatever works good for you. Okay, but I do think whenever you are new in the OR, try to do things textbook. Okay, people will show you, oh, well, this is a trick I use, or this is what I do, and this makes it easier for me. And then you work with another preceptor the next day, and it's completely different. Why are you doing that? That's so annoying. Don't worry. Welcome to anesthesia. Okay, when encountering difficult bag mask ventilation, it is essential to follow a structured sequence of events. Okay, good positioning. So we want to minimize airway compression and optimize alignment. Single hand ventilation may be attempted. That was very loud. Okay, one hand securing the mask, one hand squeezing the bag. Sniffing position, two hands. Oropharyngeal airway, nasal airway, LMA. All right, if you need to, proceed. Unfortunately, if you cannot get a supraglottic airway device, if you cannot awaken the patient, if this is an elective procedure, you're going to cut their neck. You don't want to have to go down that route. You really don't. But don't keep failing at an airway and not cut their neck. I know that sounds terrible, but trust me whenever I say this. You will get hosed. You will pay out 7 or 8 figures and probably not be able to practice for a very long time if you kill somebody and you have not done everything you should do and follow the algorithm. Okay? And you have to know how to do this. You have to be able to do this very quickly and very reliably. And the quickest you're going to do it, crike, is probably a minute and a half. And the hardest decision you'll ever make is when to proceed with a cricothyrotomy. That's the hardest decision you'll ever make. All right? But once you drop everything and you start doing it, proceed forward. Two-hand mask, however works good for you. Ideally having help there. These are ways you can do things. I like letting the vent breathe for me rather than letting my nurse bag for me. So I'll set my vent to pressure control. Okay? So pressure control, 15 of pressure, 5 of PEEP, whatever you want your rate, normally 12 to 16, okay? And then holding a good mask seal. Because unless you've really trained that nurse, close the APL, no, close the APL. Okay, squeeze the back, press the flush button. They don't know what that means. And they're freaking out. They're doing this because they're not used to coming up there with you. And who's calling for help? Okay, so, and try to prevent it from getting to that point. 99.9% of people can be ventilated safely with 2 hands in the ventilator, okay? Typically the people who can't be have some airway abnormality that you probably knew going in. Very rarely is someone unanticipated, difficult to intubate and ventilate. There's probably going to be something that clues you into that, or they're not paralyzed and their vocal cords are shut and they're having a laryngospasm, because that can happen. Because if you have somebody light, if you induce lidocaine propofol sucks, okay, you don't see anything, you don't have a good view, all right, you ventilate them some more, you look again, you don't see anything, your paralytic's worn off, okay? So now you're trying to struggle with an airway. Now the patient's light, you've simulated them multiple times, their paralysis is gone, and they're having a laryngospasm, and you're not identifying it. That is what happens so many times when people get in that situation. That's why a lot of times, you'll see many of us, we rarely use succinylcholine. A lot of times we're using rocuronium. So there's a couple definitions we need to know. A difficult airway is whenever a trained provider encounters a challenge in face mask, ventilation, laryngoscopy, intubation, or all 3. Okay? This can be due to anatomical variations, pathological changes, inadequate positioning. You have to effectively manage these, and you have to recognize these challenges. Failed airway. We don't want this. It's okay for something to be difficult. We don't want to fail at it. Okay, A failed airway occurs when tracheal intubation cannot be achieved after multiple attempts, okay, including alternative methods like a supraglottic airway or invasive techniques. Recognizing a failed airway promptly is essential to prevent severe hypoxemia. Ensuring a timely escalation to emergency procedures like a cricothyrotomy or a tracheotomy, or tracheostomy. And we don't trach people, we cric people. You have to know how to do this. You have to know how to manage it. Now, difficult face mask ventilation. This is characterized by issues like inadequate seal, excessive gas leak, high resistance to airflow, poor chest rise, inadequate end-tidal CO2. That's your big one. Rapid oxygen desaturation. Laryngoscopy and intubation challenges. So difficult laryngoscopy occurs when the vocal cords are not well visualized. Sometimes even with optimal techniques, you cannot get the ET tube to the vocal cords due to anterior placement, and we have airway tools to help with that. Video laryngoscopy, supraglottic airway devices, difficult supraglottic airway ventilation. If it's not possible to ventilate with an LMA, all right, or you have very, very poor ventilation with it, unless it's an emergency case, you should probably consider waking up. All right, do not proceed. There is nothing wrong with waking that patient up. I don't care if the surgeon's pissed off. Okay, they can be mad all they want. You're being safe. It is about the patient. Difficult or failed tracheal intubation. After multiple attempts, you need to know when to stop. Okay? At-risk extubation should be approached cautiously with backup plans in place. So if you have a difficult or failed extubation, so someone is spontaneously ventilating, they have a loss of airway patency, they're not able to ventilate on their own. I actually had a failed extubation probably 6 months ago. It was a net case. I got report from, actually got report from Dr. Heck, ironically. He's like, oh yeah, easy airway. That's what I was told. And he probably mumbled, and we did a fiber optic or something along those lines. Okay, so get this guy. I have him sitting up at the end of a big, net case. He's got a C collar on. He's, got 8 liters a minute ventilation. I've got an oral airway in his mouth. I'm like, I'll just take his tube out. He instantly obstructs. Instantly. All right, and I position his head, do a jaw thrust. All right. And I'm like, I'm not getting anywhere with this guy. I do a nasal airway in addition to my oral airway. Still not getting anything. And I call the desk out, or I tell the nurse, I said, hey, call 4562, which is our anesthesia number. Like, just tell them I want an extra set of hands back here. My stats are 100%. Okay? This is me doing that. I've done this for years. Okay? CRNA walks in, and she's very, very nice, not necessarily very, very helpful. And like, hey, she's like, was this the case that him and Dr. Kelsey did a fiber optic on? I'm like, I have no clue. Like, that wasn't what I was told. She's like, I'm pretty sure. We get a third provider in there, and this guy's, I don't know, had a great reserve. Had he not had a great reserve, I would have proceeded with intubating. We messed around with this guy. We shoved, and this was so weird. We shoved an ET tube just back his throat, and that was just enough. Like, not intubating him, literally used that to press that tongue back, and he also went, like, oh my gosh. I'm like, we're gonna have to reintubate this guy. He's like, oh, hey, let's give him a minute. So we have this guy sitting there with 2 nasal airways in, an oral airway, and an ET tube. This is Kelsey and Kristen. I'm like, this is nuts. What are we doing? I'm just gonna reintubate him. He's like, are you sure? Like, I'm like, I don't know. Okay, I'm like, he's ventilating. I'm like, let's just give him a minute. We sat back there 15 minutes. This guy still was not rousing. I'm like, nope, we're just gonna intubate him. We were re-intubate this guy and extubate him the next day. He had terrible airway swelling. Poor handoff, but difficult or failed extubation. The big thing was we got him ventilating. All right? And it's one thing to have somebody ventilating with an oral airway and you take them out deep, okay? But if you can't leave them with that PACU nurse and they can't at least troubleshoot that airway, don't do that, especially with weaker PACUs. Difficult or failed invasive airway, anatomical abnormalities, decrease your success in placing an airway into the trachea through the front of the neck. You don't want to be in that. Failed, it's terrible, difficult, high likelihood if somebody has a neck mass. Inadequate ventilation. You have to have end-tidal CO2. If you don't have end-tidal CO2, you're not ventilating. And if you're somewhere that you are not comfortable, okay, say you're called to the floor, and you don't have your tools, you don't have your anesthesia machine. Like if you look at closed claims data, if you look at where lawsuits come from, it's NORA, non-OR anesthesia, which includes intubating people outside of the OR. Being called to codes, that's when things go wrong, because you ask for something and they don't have it and they don't know what you're talking about. Okay? That's why you oftentimes see airway bags, you see go bags, you have everything you have in the OR right there with you. But if you cannot ventilate them, if you cannot get adequate end-tidal CO2, and they're desaturating, something is wrong. And if it is an urgent or emergent intubation from somebody who is apneic, coded, okay, it's okay to go ahead and relax them. Okay, they might, still have some reflexes intact, and they could be spasming. That's why you can't ventilate them. All right, there's nothing wrong with giving an additional dose of relaxant. Okay, you have to know this. You have to know this. This has to be something at 2 a.m. If I wake you up out of a dead sleep and have you run to a code, you can troubleshoot. Okay, this difficult airway algorithm, this is what we have to do. There is a disclaimer, and I like this. These guidelines aim to standardize the management of difficult airways, improve your first attempt success rate, and enhance safety during airway procedures. These emphasize minimizing the risk of adverse outcomes like brain injury or death. Okay? CPR, trauma to airway structures, dental injuries. These advocate for you to be ready, to have good decision-making capability with specific patient-related factors and procedure type. The choice of techniques and agents can be tailored to the patient's condition and your expertise. Okay? And the procedure's requirements. There are also environmental and institutional limitations. Okay, so lack of a device. And this can play a role in optimizing your management. This is a framework, okay, and this should guide you in handling a difficult airway. Okay, a proper airway evaluation. This is intended to identify the presence of upper airway pathologies, anatomical anomalies. Okay, measurement of facial and jaw features, anatomical measurements and landmarks. You can do imaging. You can do a quick look with a bronchoscope at the airway. You can have a CT scan. All right, good airway evaluation. You should have a phenomenal airway evaluation when you think that someone is going to be very difficult. Okay. Now, I'm not saying that you're going to be in an endoscopy doing a 5-minute airway assessment on every colon you do. All right. That's impractical. Okay. However, those people that make you go, something's not right here, or this is probably going to be difficult, those are the ones that you're going to spend extra time on. And we've talked about who can be a difficult intubation. We've talked about those congenital abnormalities. We've talked about those that have maybe some other risk factors. I can't remember if I mentioned this. I don't think I did. Diabetes. Okay, if you have long-term diabetes, you have glucose that builds up in your joints that hardens them, okay, that makes neck mobility very difficult, okay? Trauma, okay, if somebody comes in from a trauma, a car wreck, a car crash, they're in a C-collar, that becomes very difficult. If you have diagnostic imaging, that can be incredibly handy, but you may not have time. All right, if you walk in and somebody has already attempted and they've called you because they need help, you're not going to have time to do a 5-minute assessment. Okay, what's been done, and then you do something different, okay? Know what patients are likely to be difficult. Or whenever you walk in and someone has attempted the airway, find out quickly what's been done and how you can change and optimize things. Before anesthetizing anybody, you should have assessed that airway for risk factors, anatomical deformities, or conditions that increase the likelihood of difficulty. This includes reviewing their demographic information, any records, and diagnostic findings. A history of difficult intubation is the #1 predictor of another difficult intubation. Okay? If they tell you if they can tell you they were hard to intubate, if they tell you I had a severe sore throat, okay, or there's a note in the chart that says difficult intubation, all right, odds are they're going to be difficult again. Now, if you have somebody who's lost 130 pounds, their airway is completely different. People that lose 20 pounds, their airway can be completely different. Okay, your airway can change. It can. Some people who are easy to intubate become harder, and vice versa. Okay, but that doesn't mean that you should be cavalier with things. Now, before you proceed, okay, with an elective or an urgent or emergent procedure, you need to have documented. You need to have your plan A, B, and C ready, and you need to know what to expect. If you have somebody with a lot of facial hair, you should have lube, you should have tegaderms close by. Okay? You should have your oral airway, you should have your LMA out. Okay? You need to be very, very cautious. If you have patients that have GERD, hopefully you've treated with an H2 receptor antagonist. Okay? If you have somebody who has a high likelihood of aspiration on induction, say they have a bowel obstruction, do they have an NG tube in place? All right? Well, they came down from the floor and they don't have one. You can put one in. You're a nurse. All right? If you take a bowel obstruction back to the OR and they have an NG tube and you don't have it to suction, you are asking for trouble. Well, I only have one suction. Get it from the net tune, get it from the OR. Okay? Continuous suction while you're going to sleep. If you have somebody with a bowel obstruction and they do not have an NG tube, put one in. I cannot emphasize that enough. All right? You are rolling the dice, okay, if you don't. If you've had trouble ventilating somebody and you've blown up their stomach, decompress it after they're intubated. Okay, that will make things easier on emergence. And be very careful with certainly taking out their tube. Dr. E is probably going to pop in here in just a moment. We'll keep going. Anticipated or unanticipated. There are two types of difficult airways. There's the anticipated. Okay, these are the ones that we have everything ready. We've got our video scope, we've got our LMA, I've got my buddy in the room with me, we've pre-oxygenated, maybe we're attempting an awake intubation. These are the ones that we're ready for. And they typically go just fine. It's the unanticipated, it's the unrecognized, it's the emergent. These often occur without warning. They require quick adaptations. There may be a lack of proper positioning or equipment. Emergency algorithms have to be followed, and they have to guide your decision making. They emphasize oxygenation, okay, and escalation to invasive techniques when non-invasive methods fail. The unanticipated difficult airway is the one, all right, that you have to be ready for. If you have a code, if you are called to the ER or to the ICU to assist in an airway and multiple people have tried, that's whenever you really have to look around and reassess what's with you. I was doing an in-house call, it's probably a year and a half ago. I got called to the floor. Hey, we're coding somebody and we can't get their airway. All right, so I run up, and our call room is quite a ways away, so I didn't have time to go and grab our airway bag, so I run straight up there. And, I know who's probably tried. I know it's an RT. I know it's probably, a medical resident. I show up and they're doing CPR with a guy on the floor. They went to ambulate him and he fell. So I'm now trying to intubate this guy on the floor. And you know what they hand me? The blade I don't use and a tube that's too big. They hand me a Miller 3 and a 902. Yeah. And no stylet, of course. So, this guy's completely floppy. I don't know, it's probably been 10 minutes that they've been doing CPR. I go to look. I have a somewhat of a poor view. It's got secretions everywhere. They can't get me suction. Put the tube in. Pretty sure I'm in, but I'm like, I need end-tidal CO2. We don't have any. Like, I've got fog, I've got breath sounds, but I'm like, I need end-tidal CO2. Or if you can't give me that, get me a bronchoscope or a videoscope. So while they're running for everything, the guy pinks up and we get a rhythm back at the next pulse check. So, was in. That was total luck. Had a terrible view. But now I take the airway bag with me to the call room because of that. So if I have to run somewhere, I have my tools with me. It's things like that you have to be ready for, okay? The 1,000 airways I've done before that, okay, made it to where I was lucky enough to get that, all right? And sometimes following your gut and following your instincts on things is exactly what you need to do. If your gut tells you, hey, I should probably pull this patient up, you should probably do it. Hey, I should probably, get a troop pillow. I should ramp them better. Whatever it is, Follow your gut. Okay? So have a pre-formulated strategy with the management of your airway. Okay? This should identify whether an awake intubation is needed. This will help you determine the feasibility of a non-invasive versus invasive approach and ensure you have a backup method available. Surgery, cooperation of the patient, equipment availability. These are all things that influence the technique and the choice. It's okay to do an awake intubation. There's nothing wrong with that. However, pediatric and uncooperative patients may require a modified approach, some slight sedation. Now, if you have somebody who's alert and oriented and consistently refuses, okay, and they are going to be a difficult airway, all right, that becomes very, very difficult, okay? You may end up settling with, I'll have you sedated, but, we need to have you still breathing on your own, okay? Those are very, very challenging. Sometimes when you're anesthetizing somebody and you give them a lidocaine neb, and it starts to get hard for them to breathe, they freak out and have a panic attack. And you end up giving them some sedation because it is harder to breathe whenever your vocal cords are numb and your airway's numb. But have a strategy in place. Awake intubation, if you cannot adequately ventilate somebody, that's whenever you're going to have to proceed to something invasive. If you can't ventilate them. If you can ventilate them, all right, you got all the time in the world. Whatever you need to do, probably 3 or 4 intubation attempts and then wake them up, as long as it is not an emergency, okay? And if you have difficulty with an emergency invasive airway, all right, that's bad. Who's your backup? Who do you want there if you have trouble with an invasive airway? ENT and general surgery. That's who you want. Perfect timing.
Are you done?
No, we're...
What am I?
No. I mean, I've still got a little bit to go, but if you want...
No,
Okay.
you finish and then we'll
Okay, sounds good.
just text me.
All right. So, identify a strategy for awake intubation, okay? This is when it's appropriate. If they have a history of difficult ventilation, if they're at an increased risk of aspiration, if they are likely incapable of tolerating a brief apneic episode, or there is expected difficulty with emergency invasive airway rescue, okay? So the patient who comes in with Ludwig's angina that has severe airway swelling and compression, all right, that has no mouth opening, you're probably not going to give them a slug of propofol and paralyze them and try to intubate. Go ahead.
What device were they using in the last slide?
That's an intubating LMA. All right. That was the airway rescue tool before video laryngoscopes were in. That was late 90s to probably 2010. You saw those a lot. I've used them a couple times. You should be familiar with them, but do you ever use one? I don't even know if we have them anymore. But
We got one at the Navy.
yeah, perfect.
Car somewhere in the back.
It's dusty. You take it out and it like crumbles.
Degrading.
Yeah, exactly. So cognitive aids like that algorithm are very valuable. Most places now have an emergency manual on the anesthesia cart or in your in your go bag. Those are very, very helpful. Okay, that will help guide you through. And there's nothing wrong with pulling something out and looking at it as a reference. Okay, if it's 2 a.m., you need all the help you can get. And knowing when to escalate, okay, is one of the hardest things to do. So if they can be adequately ventilated, but they're difficult to intubate, you've got plenty of time, okay? If this is an elective case, all right, maybe you want to do something that is completely reversible, okay? So you could give fentanyl and Versed. Well, you can reverse that with Narcan and Ramazicon. And if you think they're going to be that difficult, and you think you can ventilate them, you can take a look. All right, you can probably get somebody sleepy enough to where they're breathing and they open up their mouth and you can put a video scope in and see, do you have a decent view? All right. There are a number of ways. However, the big things are, if you anticipate that they are going to be difficult to ventilate and difficult to intubate, it should be awake. All right. It should be some modified version of someone spontaneously ventilating, all right, and then intubating them. One of the big things that you need to be aware of is the oh-so-scary cannot ventilate, cannot intubate. This is rare, but this is life-threatening. So the airway cannot be secured, and they cannot be ventilated well. Emphasis here is placed on timing, oxygen saturation monitoring, and limiting attempts at tracheal intubation, because further attempts are just going to cause more airway swelling and trauma. If you have the ability to mask ventilate and you lose that due to repeated airway trauma, and now a supraglottic airway device is failing, you're going to have to escalate to an advanced technique. Okay? Teamwork is essential. Monitor your time, monitor your number of attempts. Okay? If I've DL'd twice and you've DL'd twice and a third person shows up, all right, ideally do not let them DL. Do not let them VL. We should probably go ahead and wake this patient up. That's very rare in anesthesia that happens. However, okay, you need to be doing something different each time, and there comes a point where you say, we're not going to continue. We need to wake this patient up. If you have difficulty with emergency invasive airway rescue, this is scary, okay? This is emotional because we are not used to abandoning intubation attempts, okay? You have to remain composed under pressure, and this is where you have to make decisive action. And sometimes it's hard if if you're one of those people like in a code situation, you get nervous, you get anxious. It is so much worse whenever you're the one that is in charge of everything. It is so much more nerve-wracking and challenging. However, this is whenever you fall back on, I remember this lecture, I remember what he talked about, I'm going to go ahead and cut the neck, all right? That's what you have to do. You have to proceed to something invasive, all right? You're trained in this. We're going to practice cricothyrotomy. We're going to talk about it, okay? If you cannot, and if you're going that way, you should have them be paging general surgery. You should have them paging ENT, having someone there that can help you, okay? All you're trying to do is keep that patient alive and ventilate them until you can get some further help without an anoxic brain injury, okay? Here's your steps. Airway management of an unanticipated or emergent difficult airway. If you do not ventilate well, okay, or you miss your first intubation attempt, the first step should be call for help. That is what you'll be judged on, as when did you call for a second set of hands, okay? And if you're by yourself, if you say, well, there was no one there for me to call, there's always someone to call, okay? Even if it's an RT to help hold the bag or hold your suction, or if it's another nurse to draw up drugs, okay? Ideally, it's another anesthesia provider. Optimization of oxygenation, okay? You should ventilate them. Ventilate, ventilate, ventilate. Use of a cognitive aid. You should have something handy. Even if it's saved on your phone, pull it up, look at it. Someone reads that? No. Okay. Non-invasive airway management devices. Oral airway, nasal airway, LMA. Combination techniques, okay? So this is whenever you are using, say, video laryngoscopy and a bougie, all right? Using multiple tools, all right? And then you have invasive airway management interventions, and then ECMO would be, you'd have to be at a huge center, that'd be the giant backup, that would be completely last resort. So upon encountering an unanticipated difficult airway, the first step is recognizing the problem early and promptly calling for help. Simultaneously, you're going to focus on optimizing your oxygenation with your bag mask ventilation, okay? 2 hands, okay? 2-hand mask on the vent. Don't let your nurse bag for you. A million reasons to not, but the best thing to do is have your flows all the way up, 2-hand mask, okay, and you ventilate. Let the vent breathe for you. Use of a cognitive aid is so critical, okay? If you cannot ventilate, all right, and you don't have an LMA, and you should try LMA placement. If you cannot place an LMA and you still can't ventilate, and you don't think you can wake them up, all right, then you're going to proceed to something invasive, all right? But you should have an identified preferred sequence of events. If you were in your OR, you should know A, B, C, D, and E, okay? D and E are what we don't want to get to, all right? But if you DL and then you VL and then you call for a fiber optic scope, or for me, if I cannot see a view with a McGrath, I'm probably going to get a CMAX scope. The D blade is a little bit more curved for an anterior airway. And if I'm not getting into that, I'm going to switch to a fiber optic approach or wake the patient up, all right? That is what you have to keep in mind. You have to have a sequence of events. Let's talk airway tools. We've talked nasal airways, we've talked oral airways, all right? This is how to accurately size them. So nasopharyngeal airways should be soft, they should be lubricated. ideally using some vasoconstrictive agent beforehand. They're great for semi-conscious patients, okay? They're less likely to stimulate the gag reflex. Now, key considerations with sizing, okay? Measure from the nostrils to the tragus, all right? And phenylephrine, Afrin, anything like that. Oropharyngeal airways, useful in unconscious patients who don't have a gag reflex. Proper sizing, okay, of the angle of the mandible, okay, to the mouth is very crucial. Insertion techniques, use a tongue blade. I harp on people all the time for this, use a tongue blade. I can't tell you how many times I see someone pull down on the chin, flip the airway in, and then the tongue is facing down. Pay very close attention to that, okay? Sometimes inserting them upside down and then rotating, I said upside down, turned 180 degrees and then rotating can be helpful, but regardless, it should hopefully be a very gentle insertion, okay? If they're clenching their teeth, all right, and you can't put in you can't put in an oral airway, all right, you probably need to give more anesthetic or relax them. Okay, sizes of nasal airways, okay, 28, 30, 32, 34 French, okay? 34 French is gigantic, 30 to 32 in most adults, 30 for women, 32 for men, okay? If they're on anticoagulants, be very cautious. Now, you can use a nasal airway to dilate the nerve for a nasal intubation. You can do all sorts of things. Lidocaine jelly is probably my go-to along with some Afrin, okay? It's great for semi-conscious patients, patients who have obstructive sleep apnea, and if you can get it in earlier, so if I anticipate waking somebody up with a nasal airway in or think I might want it, I'll probably place it 30 minutes before the procedure's over with. This way, if there's any bleeding, it's already stopped. This way, if I have lidocaine jelly, it's already numb. I don't even know it's there. Oral airways. Okay, they're very efficient. You should know your sizes. 70 millimeter, 80 millimeter, 90, and 100. 100 is red, okay? I typically say red for men, yellow for women, so that's 90. Green is 80, white is 70, black is 60, light blue is 50, okay? The 50s, 60s, and 70s, those are pediatric airways. Very rarely will a green airway, like a tiny one, be useful in an adult, okay? You want a properly sized airway. Once again, if they're clenching their jaw and have intact gag reflexes, they may retch, they may vomit, they may aspirate, okay? Pediatric oral airways are great because kids have such a large tongue. LMAs. Gosh, these are this changed, and there's a couple things that changed anesthesia. LMAs, end-tidal CO2, and pulse oximetry. None of us would have wanted to do anesthesia in 1980. There was no iPhone to shop on. There was no computer to look anything up. You had to mask and ventilate your patients, sometimes the entire case. There was no LMA. All of your inhalational agents were crap. Your induction drugs were terrible. You had potent vagolytics. People died, We just figured out how to treat MH. No one would have wanted to do it then. Anesthesia is so much better now. So LMAs, laryngeal mask airways, they are supraglottic devices. They sit in the hypopharynx and cover the glottic opening, okay? There are generations of LMAs. You have to know that. You have to know that. Not all LMAs are created equally. Size is critical to success rate. There are suggested weight ranges, okay? 70 to 100 kilos, 100 plus, 50 to 70. However, in the package insert, if you ever want to know how to use a tool, who do you go to? You don't go to me, you don't go to Dr. Nagorny, you don't go to anybody else but the manufacturer. They're going to tell you how to use their tool, okay? One thing that I have students do whenever they're with me is if we use an LMA, hey, let's read about it. Let's make sure we know how to use this. Because you'll have some people that don't want to put them on the vent. Some people only want to use PSV Pro. They don't want to use pressure control. Some people don't ever want to use an LMA. And there are times too. All right, with your first generation LMAs, these were mask replacements, okay? They allow for spontaneous or positive pressure ventilation with peak airway pressures below 20 centimeters of water. Why is that? Where's that 20 come from? What is that same amount of pressure as? Go ahead.
I'm lower esophageal.
Yeah, so blow open the lower esophageal sphincter and increase your risk of aspiration. Second generation LMAs, okay, they have features that mitigate aspiration risk. Oftentimes they have a gastric drainage channel, enhanced cuff designs, a reinforced tip, and you can tolerate higher ventilation pressures. Okay? You need to know. So the classic and the unique are first generation. They were mask replacements. While effective for ventilation, okay, they lack those features to help mitigate aspiration risks. LMAs are suited, okay, in emergency situations to help ventilate, but otherwise fasting patients. They have to be fasting, okay? Emergency surgery. If they have a bowel obstruction, if it's a trauma, unless it's a rescue device, you're not placing an LMA for those cases. Second generation LMAs, the LMA Pro Seal, the LMA Supreme, the iGel, the Aurora Gain. These reduce aspiration risk and are suitable for higher pressure ventilation. Each one has a different pressure limit, okay? And it makes them ideal in those difficult airway scenarios. Indeed, current difficult airway algorithms support the use of second generation LMAs for the previously mentioned reasons, okay? SADs, supraglottic airway devices, okay? Second generation LMAs. So keep in mind, it is very important to know the difference, okay? 99% of people are going to be using an LMA and they keep somebody spontaneously ventilating, or they use PSV Pro. Okay, and then if they have trouble ventilating, sometimes they'll switch them on pressure control. What does PSV Pro stand for? Say that again?
Protected.
Okay, yeah. So pressure support, ventilation, protection. Okay, so what's the protection part of it? How does it protect you? And what happens after so long? Whatever backup mode. Yep. Typically it's just pressure control. So your P inspired, when you set your settings on PSV Pro, your P inspired is technically your backup. It's your pressure support that you can change. Okay, so whenever they go apneic after 30 seconds or however long it is, and it kicks on that protection, all right, it will deliver your pressure inspired. Okay, know the difference. The use of second generation supraglottic airway devices reduces the risk of aspiration. You can use higher pressure. I use the Ambu Aurora Gain, and this is interesting. Studies indicate that the overall incidence of aspiration with an LMA remains low, approximately 1 to 2 per 100,000 per 10,000 cases. Okay, second generation devices further reduce it. What if I told you that you are less likely to aspirate with an LMA than you were an ET tube? Would you believe that? It's actually true. Your aspiration rate with an endotracheal tube is actually higher than it is with an LMA. But who are we putting ET tubes in? People with full stomachs, people at risk for aspiration. Okay? So keep in mind who we're going to use an LMA with. They have to be adequately fasted. Normally they have to have an adequate mouth opening. Somebody with radiation to the head or neck, you have to be very cautious with. All right? And the other big thing is if you have a gastric drainage port and you expect regurgitation, they literally tell you to place a gastric tube down and decompress the stomach. So somebody with GERD, it can be useful. Most people are not super familiar with doing that. The gum elastic bougie, I hate these. It's just a me thing. Not a big fan. This is great for that 2B or grade 3 view. All right, so you're going to take the bougie, you're going to pass it. So normally what you're doing is you're seeing the bottom of the epiglottis, or you're seeing the epiglottis and it's covering the majority of your glottic opening. And so you're going to try to pass this in. The way you hold it, you want that curved tip to be up, and you want to feel the stylet bounce on the tracheal rings, okay? It's not always felt, and the downside to these are this person's hard to intubate anyway, so they have a lot of redundant tissue. And whenever you advance that tube in, oftentimes it can get hung up on the corniculate. Sometimes you have to lube the tube. And I've seen tracheal perforations with that, and that's a big deal, okay, if someone's really, really rough with it. It can be useful as a tube exchanger, but I'll show you guys in the lab one thing that's easier to do. A lot of times when people place a bougie, they'll have it out of the mouth like this, okay? If you'll actually bend it down like this, tube exchanging wise, it's much easier, and passing your tube. Sometimes you have to like kind of hook your hand in the mouth and lift up on the jaw to pass the tube in, but I'm not a big fan of it, okay? very rarely, like if I'm with a student and they're like, oh, can I have a bougie? I'm like, let's not. Let's try something different. See if you can make your view better, or we'll use a video scope. Alex, do you ever use a bougie?
I just like in rare situations with the McGrath and everything.
Yeah.
Every like super rare. I mean, I think maybe like 2 or 3 times in my career.
I will say, and I mentioned combination techniques earlier, one of my favorite rescues for like a, oh crap, this is going really, really poorly airway. And normally that's, I can put a video scope in and I can't get the ET tube to make the curve because the airway is so anterior. I'll take a bougie and put it in the mouth, and I'll take a pair of McGill's and lift the bougie up, then put it in the airway, and then slide it in. That's a combination technique. We're using McGill's that you would normally use in a nasal intubation. You're using a bougie and a video scope. All right? Yes. So, it's a great question. They're forceps, so they look like a big pair of Kellys, but they're curved, and instead of being sharp on the end, it's like just a grasper and a clamp. So we use that in nasal intubations to grab the tube and lift it up to then pass it into the glottic opening. Okay? And we'll show you that. But yes, keep that in mind for combination techniques. So, and you can use a bougie and just use a video scope. You can use a video scope and a bronchoscope together. If you're having a hard time passing your bronchoscope, you can put a video scope in the mouth and then pass your bronchoscope. Now, it can become a little crowded, but it works. Flexible scopes and fiber optic stylettes. These can be used for airway evaluation. I prefer to stand behind the patient, traditionally like how I always am. I see people who will stand up front. The downside is if you're doing that and the patient needs ventilated, who's going to ventilate them? You're in an awkward position. And normally I have them sitting up. If they are somewhat awake or sedated, that's very traumatizing to look at. One of the things I'll do is I'll normally take a blue towel and I'll place it over their eyes and say, hey, I'm going to cover your eyes because I'm going to spray more numbing medicine in your throat and I don't want it to get in your eyes. This way they're not physically seeing the giant tube or the giant scope. All right. These are very, very useful, great for taking out foreign bodies. You need to know how to do basic bronchoscopy. We're not doing interventional bronchoscopy, okay? But you need to know how to inspect an airway. You need to know how to check for double lumen tube placement. And at times, you've dropped something down the airway, you may need to retrieve it. Like if you knock a tooth out, okay, you should be able to go down and get it out. Video laryngoscopy, tons of video scopes. This is, it's made anesthesia so much easier. All right, some places do a video intubation, video laryngoscopy every time. One thing that you're going to see is as there's a push for more and more disposable laryngoscopes, video laryngoscopy is cheaper. Okay, it's cheaper because blade replacement for McGrath is like $6 to $12 depending on which one. Okay, the disposable laryngoscopes are like $12 to $15, and then if you don't get it with that, you then go to the McGrath. But the number one rescue for a failed video laryngoscopy is direct laryngoscopy. So when might video laryngoscopy be impossible or darn near impossible? What situations? Okay, yeah, so someone actively vomiting. What else? Did you say bleeding? Mm-hmm. Yeah. Airway trauma. That's going to be the big ones. And that's why you need suction there. And then knowing how to clean off the camera fairly quickly. The glide scope, this was like the OG back in the day from like 2000 to probably 2015. These were very, very popular. And we have a glide scope upstairs, but you have to wheel them from room to room. They were like $20,000 to $40,000, depending on what all toys you got with them. But they were reusable. Then they made this reusable pieces. It's like subscriptions. Like the ideal model of a business is to have a subscription-based model. Like McGrath, disposable handles. I'll give you the video scope free. Just buy my blades and my batteries. Yeah, that's why they're everywhere. Okay. Here's the thing: the blade should be inserted midline with video laryngoscopy. Okay, and technically, a grade 2 view like that is actually fairly ideal. Okay. However, if you have trouble manipulating in the mouth, you can actually back out your video scope. Okay, to give yourself more room to manipulate your ET tube. And a lot of people will insert their tube turned 90 degrees, okay? And then you have to be careful with dragging your cuff across the teeth and cutting it. If you have somebody that has really, really tight mouth opening, you can cut your cuff. So you'll intubate them and you'll attempt to blow it up. You're like, oh, my pilot balloon doesn't feel right. And you'll go to ventilate and you hear a big leak and then you have to replace it. So getting good with video laryngoscopy, it's an essential skill. The CMAC, the Karl Storrs, I mentioned the D-blade earlier. The D-blade has a little bit more of an acute angle. The CMAC also has a fiber optic scope on it. With the fiber optic scope, you can spray lidocaine through it. You can pass a catheter through it. Can be very, very useful. It's great for checking placement of a double lumen tube, and which we will talk about that in our subsequent lecture. It's great for checking placement to make sure you are not right main stemmed, and you can actually go around the tube and you can inspect if you have a lot of airway swelling. But normally places only have one CMAC scope if they have one. Okay, McGrath, this was like the first version. Now they look a little bit better. The one thing to keep in mind, these are not disposable. Don't throw them away. You don't necessarily need to have one yourself. Go ahead.
Sorry,
You're fine.
CMAC and DMAC, are those
CMAC D-blade.
the same?
The D-blade is one of the blade options for the Karl Storrs CMAC scope. They have a couple different ones. They have a pediatric one, but it's a little bit more of an acute angle. McGraths are not disposable. Don't throw them away. They're to be wiped down. The covers are. The cover needs to click on. If it has not clicked on, you'll put it in the mouth and your cover will have slipped and you will not be able to see anything because it will be obstructing the camera. The battery packs are self-contained. They are proprietary. So this is what you do. Alex, I'm curious how you guys do it. Okay? In the morning, whenever I check my McGrath, I turn it on. It'll tell you how many minutes of runtime. 180. I turn it right back off. Okay? Whenever I'm inducing, I have it beside me. I haven't turned it on. Okay? Whenever I'm ready to intubate, I'll grab it, turn it on, and intubate. I don't want to run that battery down. That is an additional expense. I see people like leave it on during induction or like afterwards, turn it right back off. It's a lot of money. And I always say, like, if you can do things to save, you're helping out non-revenue generating departments, okay? Because we can generate revenue, but there are lots of departments in the hospital that can't, and the only way that they're going to get a raise, the only way that they're going to get competitive pay is if they're saving somewhere. So, like, throwing everything into the red sharps container. Don't throw paper in there. Don't throw trash in there. That stuff's weighed. Stuff's expensive to get rid of. These are trash. Sorry, they are. I hate channeled scopes. These were the knockoff glide scopes. The little camera piece slides into it. It clicks. They're just trash. Pentax, the Rescue Scope, the King Vision. These all try to do what the McGrath did before the McGrath. And you have to load your ET tube in that channel to the side here. They just never, I never enjoyed them. They never worked well. This is the air track. There's a question on the C exam that asks for a video scope that uses a series of mirrors, prisms, and lenses. It's the air track to magnify it. Okay, like other channeled and video laryngoscope devices, good view of the glottic opening without neck manipulation. It has 2 channels. You should be familiar with it. But these are very regional. They're in the Northeast. I've never seen one of these in person, but you should be familiar with them. Always confirm placement. At minimum, in tidal CO2. Okay? What if you have bilateral breath sounds, but you don't have in tidal? What do you do? Okay, yeah, check the connection. All right, but like when you were ventilating them, all right, and squeezing the mask 2 minutes ago, you had good in-tidal CO2. Where's the tube probably at? Probably in the esophagus. You probably have referred breath sounds. Okay. Now you can have a bronchospasm post-intubation if somebody's very, very light. Okay. However, you're going to have elevated peak airway pressures. There's going to be a couple other indicators as well. Fog is not interchangeable with in-tidal CO2. Chest rise is not interchangeable with in-tidal CO2. In-tidal CO2 is the gold standard. If I ask you for the best method to confirm placement, what is it? Okay. If you don't have in-tidal CO2, all right, and it was working 5 minutes ago, your tube is probably 99% of the time not in the right place. Okay? And what do you do in that situation if you are unsure? You take it out and you ventilate them like you were 3 minutes ago. Don't leave a tube in. That's how people die. If you have a tube in and they desaturate, and you're squeezing, but they were easy to ventilate before, take the tube out. It's probably, and sometimes the tube can go into place, but who's pulling your stylet when you're moving things around? It can happen. You can have a supraglottic ET tube to where the tip is in the glottic opening, but the balloon has been inflated, superior to it. So any positioning, that tube will come out. That's very, very scary. These are your algorithms from the ASA. You have to know these. And they're everything we talked about. Call for help. Is there a difficulty with ventilation? Can you do an awake intubation? Can you limit attempts? Can you wake the patient up? Do you need to cut the neck? So here's the pediatric guide. Invasive access is normally needle cricothyrotomy, okay? But typically with kids, very rarely will you have a cannot ventilate. You can have cannot intubate, but cannot ventilate is very rare, okay? So that's whenever you're gonna have to use an alternative approach. Those are very, very scary. The other thing with kids are, and we'll talk about this whenever we talk, and we'll do this some in lab. And at times you will intubate pediatric patients in the ER outside of the OR. If you intubate a kid, what are some priorities that you need to have in place before you leave to go back upstairs, to go to wherever, because the pediatric hospital is going to come get them? What are some things you could think of?
Make sure that they have like their specific size
Mhm.
and stuff, because not everywhere has that.
Right, perfect. What else? We just intubated them, say, for epiglottitis and croup. Should probably have some sedation. Okay? All right, how much sedation does a kid need? Lots. Yeah, lots, weight-based. Okay? Another thing I'm a big believer in, I think relaxing a kid post-intubation for transport is probably the ideal thing to do. And you should probably always be using a cuffed tube unless it is like a neonate, and you have to use an uncuffed tube. Confirming placement via x-ray before you leave the bedside. Confirming sedation orders. There's a very, very frustrating case that happened. Pediatric patient, CRNA intubated them in the ER. Kid has croup. I think they're like 4 or 5 years old. And CRNA left and I was actually called to go intubate or to do something else in the ER. So they were still down there. And all of a sudden they're like, hey, we need some help in here. So he walks back in and the patient's become hypoxic, bradycardic, the vent's still going. And he's like, oh my gosh, what happened? And so, I don't know, we were about to transport her, and she's just started moving and coughing. EMS turned her sedation down to 25. Because that's their protocol. 25 is what they transport on. They weren't pediatric paramedics. They were just regular paramedics to take this kid to Vandy. All right? And the kid clamped down on the tube and got negative pressure pulmonary edema. The kid wound up dying after a prolonged code. Yep. So, absolutely terrible. A couple things from that. All right, number one, it was kind of ironic. I had a case probably a month and a half after that where it was a similar epiglottitis. I brought them up to the OR to intubate them and left them on the ventilator there until the pediatric ambulance came. So that's a little different. You might not always have the ability to do that, especially if it's like an urgent intubation in the ER. Adequate sedation, chest x-ray to confirm, continuous in-tidal CO2 monitoring. Okay? Continuous. And relax them. Okay? Because if you lighten up a kid and they're coughing, all right, that can very well happen. That tube kinks because it's been kind of warm in the mouth a little bit and they're now moving their mouth and they bite down on it. Okay? And they take a couple good breaths while the vent's trying to drive as well. All right? Things can go bad really, really quickly. All right? Here's the other thing too. If a child is hypoxic, desaturating, and becoming bradycardic, okay, ventilate. ventilate, ventilate, ventilate. So if you had a tube in place and you don't have end-tidal CO2, and you have any doubt, pull it and mask them. If you were able to mask before, do not leave a tube in place. Typically, if a child is having a cardiac arrest, 99% of the time it is hypoxia. Okay? So, did that kid cough the tube out? When they suctioned the kid, they were getting pink frothy sputum, or was it stomach contents? They had to do an autopsy. It's terrible, absolutely terrible. So, if you're ever in a situation like that, stay close by, relax them. A couple cc's of Vec, that's enough to keep a kid relaxed for a while, and good report whenever you transport them. But this way, they're not coughing that tube out right in the middle of transport. All right, and adequate sedation. Adequate sedation.
I have a question.
Yeah, go ahead.
Is that something like that we would put if we say we went to the ER
Mhm.
to intubate, the ER doc would end up throwing in like those orders, right, for like the sedation.
No, you can do them.
We would throw
Yeah.
them
I will say, and this is very hospital dependent, like our ER, they don't intubate kids.
in.
They don't know how to handle a sick kid, so they always call us. Okay? Depending on where you go.
Okay.
But the reality is if a child needs intubated, the most skilled person should be doing it. All right, so it's probably going to be you. And then they're not going to know how to sedate kids,
Okay.
so you're going to have to probably that. Peyton?
I heard you say if you're becoming hypoxic and
Bradycardic.
you break heart, remove the tube and ventilate if you were able to do it before.
Yeah.
If you weren't, ventilate.
That's going to be a bad situation. Odds are, if a child is becoming bradycardic and having cardiac arrest, it's hypoxia.
So whose fault is it in the event with EMS turning the sedation down? Is that our fault for not educating?
EMS. That was an order, and they messed with it. It was, and that's a situation that I hate it because it's a phenomenal CRNA who's involved in it, but that was just, hey, we do this often, and we've never had an issue before, okay, and that was the big issue. That was the red flag, and so now it's handled completely different. We had a pediatric intubation last week, and like, okay, who's going to go down for it? I'm like, all right, who is going to do it? Not me. The last thing I want to be involved in. All right, here's a couple different algorithms: difficult airway in adult patients, invasive, non-invasive. You need to be familiar with these, okay? And then this is the difficult airway infographic for the pediatric patient. Ventilate, ventilate, ventilate. Okay, so a recent airway experience. This is actually a little over a year ago, okay? This was just going to be a quick case. It was like an add-on gallbladder or appy, something like that. The patient did not speak English, and a poor airway evaluation was done. Okay, obviously poor dentition, standard induction, somewhat of a difficult mask. Okay, head of the bed was up. They were somewhat adequately ventilated, and they used the ventilator to breathe for the patient. Okay, we talked about pressure control, 15 of pressure, 5 of PEEP. You can do a little higher pressure. You can do 18, but that's just keeping your peak airway pressures. That's delivering the same amount of tidal volume as long as you have a good mask seal. Okay. They had a poor view with a MAC 3, a grade 4 view. They adjusted the position of the blade, and upon sliding the blade out, they made contact with the teeth. She had caps, and those 2 empty caps, wherever she had this done, probably not in the United States. So these were just like little pegs covering the tooth, and then that one was basically coming out. But they were, airway instantly becomes bloody. Okay, take this from the mouth, copious amounts of blood, patient begins, they began to ventilate again, sats drop to 92, nurse gets the McGrath, they have a poor view with the McGrath, can't pass the tube, anterior airway. What are our options? They're now tachycardic and hypertensive, airway still bloody.
So you
Mhm.
and probably would be a good candidate for DL because they're bloody, so you would just DL this patient.
Okay, potentially, but they're a hard DL to begin with.
R2B, could you use bougie?
Yeah, could use a bougie. Okay. I said McGrath. What's another go-to? I mentioned it earlier. Yeah, glide scope or D-blade, another type of tool. Fiber optic scope. All right. Why are they tachycardic and hypertensive?
Sedation's probably going on.
Yeah, sedation has worn off. So what should you do? Oh, yeah. Yeah, with what? Okay, SIVO. All right, is that going to, when you turn gas on and you're ventilating somebody like that, what's the tachycardia and hypertension from stimulation? Okay, so if you're wanting to control the heart rate, okay, probably some narcotic is very, very useful. If you're wanting to manipulate the blood pressure quickly, propofol is probably going to be your quickest. Gas is going to be a quick second. But the downside with gas is you're probably going to expose everybody in the room to it. And turns out it's not healthy to breathe in. It's not really good for you. Ventilated again. Gas was on. Gave more propofol, fentanyl. They called for a CMAC on a McGrath. They utilized the D-blade, and they were able to use a rigid stylet. The rigid stylets typically, you can buy them separately. A lot of times they come with the glide scope, and so they're not meant to be bent, but some people will bend them. So things went wrong from the beginning. A poor evaluation, the patient didn't speak English very well. Things should have been done differently. They shouldn't have used a MAC 3 to begin with. What do you do about the teeth? What do you document? You document what happened. All right. Thankfully, we have a dentist that we can consult, and actually all of her teeth had to end up coming out. They were terrible. So that would have probably happened to anyone that did the case. But yeah, it was absolutely terrible. So the problem with that was a poor evaluation. That's where things go wrong. Okay? Do a thorough airway evaluation. Okay? If your patient does not speak English, okay, use the translator line and wait. All right? If you did not have a good look at their mouth or a good view of their neck range of motion, or if someone, you had a student do it and you walk over there and you see, okay, hey, this might look a little difficult, pause and do it again. Have all your tools ready. The difficult airway algorithm and Nagelhout chapter 24. I also, Miller and Siddell's guide, I have PDF copies for you guys. So Ashley will get those to you.
Can everyone just check if they have it